Hi, hello Aditya. Good afternoon. Can you hear?
Yes,
Can you hear me?
yes, you're audible.
Oh,
We will start at 2 sharp now.
yes.
Yes. Hello, good afternoon, everybody. Welcome to the KCIAPM Slide Seminar for the month of July. This slide seminar is being conducted by Shankara Cancer Hospital, Bangalore. And this is a special one because it comes immediately after a very successful CAPCON 2025 at PMCR at Bangalore. We all had a chance to meet there. And with us, without wasting much time, I invite Dr. Rekha P. Kumar, ma'am, Director or Lead Pathologist at Shankara Cancer Hospital, to take over the session and deliver her opening remarks before we get started with the slide seminar presentations. Rekha, ma'am, over to you.
Thank you, Aditya. As always, thank you for this opportunity to interact with the students. So, good afternoon, everyone, postgraduate students and others who have joined online. On behalf of the Department of Histopathology at Sri Shankara Cancer Hospital and Research Center, I welcome you to today's slide seminar. This time we have changed the format a little bit. Earlier we would have a mix of cases from different sites, but this time we have made an effort to choose all 10 cases, neoplastic and non-neoplastic, comprising lesions that occur in the thorax. And so we have named it something which I don't know if you can see it yet, but PGs do breathe easy, and the pun is intended. So I request the presenters of each case to keep their mic on while the consultant is discussing so that they can answer very quickly any questions that are posed to them. So we look forward to getting started. So over to you, Aditya.
To begin with, I invite Dr. Pooja from Jim's Kalburgi to share her screen and begin case number 1. Is that fine, ma'am? Dr. Pooja, case number 1. Dr. Pooja, I request you to unmute and share your screen. Dr. Pooja, request you to unmute and share your screen. I believe Dr. Pooja is having some audio related issues. She has communicated that in the group. So we'll begin with case 2 by Dr. Priyanka from KIMS Hubli. Dr. Priyanka,
Yes, sir.
yes, please unmute and share your screen. We'll go back to Dr. Pooja later. She is having some audio issues. I request you to share your screen and present case number 2.
Yes, sir. Sir, am I audible? Sir, am I visible, sir? Sir, sir, shall I start, sir? Sir, shall I start?
Dr. Priyanka, open your PowerPoint.
Oh, yes, sir.
Open your PowerPoint, yes.
Yes, sir.
Your slide one. Yes. Go
Sir,
ahead.
shall I start? Good afternoon, one and all. Myself, Dr. Priyanka from KCIAPM Hubli. I'm here to present case number 2. Given history, 27-year male with recurrent pleural effusion, and they provided pleural biopsy. With this history, we can consider the cause for the pleural effusion. This pleural effusion can be due to increased hydrostatic pressure, which can be seen in congestive heart failure, or it can also due to reduced oncotic pressure, which can be seen in hypoproteinemia condition like nephrotic syndrome, and liver cirrhosis, and it can also due to increase in the capillary permeability, which can be seen in inflammation and infection condition, and it also due to lymphatic obstruction by the tumors. uh, this is the given scanner view. In this we can see multiple tissue bit. Some areas are hypercellular, some areas are hypocellular. The higher magnification of this hypercellular area, we can see a lymphoid tissue. So with this, the common pulmonary lymphoid lesions, it can be benign or malignant. In benign, we can consider follicular bronchiolitis, a nodular lymphoid hyperplasia, and diffuse lymphoid hyperplasia. Under malignant, marginal zone lymphoma, diffuse large B cell lymphoma, anaplastic large cell lymphoma, lymphomatoid granulomatosis, Hodgkin lymphoma, plasmacytoma, post-transplant lymphoproliferative disorder. Uh, this is the higher power magnification of that image. In this, we can see monotonous population of uh, atypical lymphoid cells, which shows irregular nuclear membrane and dark condensed chromatin. And we can see a dispersed good number of histiocytes with ingested particles. We can also see increased tumor vascularization, and this is the lighter area. Higher magnification of this lighter area, we can see predominantly histiocyte with the scattered lymphocytes. In this area, focal areas also shows dense sclerosis, and the periphery of the tissue bit, we can see large area of a crush artifact, which adopt the appearance of spindle. Coming to the microscopy, section studied shows multiple tissue bits showing monotonous population of atypical lymphoid cells having irregular nuclear membrane, dark condensed chromatin with interspersed good number of histiocytes containing ingested particles. There is increased tumor vascularization and unfrequent mitotic figures. Peripheral area of tissue bit shows large area of crush artifact. Also seen focal palar area showing predominantly histiocytic cells with interspersed lymphoid cells and dense sclerotic areas. With this, my provisional diagnosis is non-Hodgkin lymphoma, possibly primary efficient lymphoma variant of diffuse large B-cell lymphoma. My other DDs are Burkitt lymphoma and lymphohistiocytoid mesothelioma. In under WHO, we can see this primary efficient lymphoma comes under mature B cell neoplasm. Uh, Primary efficient lymphoma is a variant of the diffuse large B cell lymphoma. It is a large B cell lymphoma of terminal differentiated B cell associated with HHV8 positive and co-infected with EBV, occurring as a serous infusion in the absence of lymph node involvement or tumor mass, and it affects the major body cavities like pleura, peritoneum, and pericardium. One more variant is also subtype is there, extra cavitary PL, which occur as a solid tumors in sites such as lung, GI tract, and skin and CNS. Clinical feature: patient will present with the cough and serious effusion, difficulty in breathing. Microscopy: large cells with irregular nuclear counter, condensed chromatin, and prominent nucleoli. In extranodal site, we can see effacement of the architecture and shows sheets of large malignant cells, including multinucleated forms resembling Hodgkin cells and frequent apoptotic cells. This primary effusion, it is differ from the normally B cells. That is, it is not positive for the B cell markers. Instead, it will be positive for CD30, EME, CD38, and HLA-DR. And it also positive in HIV patient for EBV encoded small RNA. Thank you.
Doctor, could you stop sharing your screen?
Yes, sir. Yes, ma'am.
Entire screen. Yesterday and Thursday.
Yeah, thank you, Priyanka. You described the cells very well, but I will present you with some more data which may help you come to the diagnosis. So let's get on. Oh, I'm sorry, this is case two. Um, I'll quickly go to case two. Okay. So the history given to you was a 27-year-old male with a recurrent pleural effusion, and you had a pleural biopsy slide, and we had a block for review. You've shown all the pictures. I think one can note a lot of crush artifact, which kind of tells you that these are kind of delicate cells which crush easily during the biopsy procedure. Again, you have shown a lot of pictures, and this is the classic starry sky pattern which was seen in the areas which were not crushed. So I would think that what we saw, as you described, was fibrocollagenous tissue, which had these crushed small round cells arranged in sheets. The exact nature of the cells, but they looked fairly uniform. There were foci of necrosis, and there were many tingible body macrophages. So what we called it was a small round cell tumor of the pleura, possibly hematolymphoid, as you also thought. But we needed an IHC really for further categorization, which we normally do whenever something is hematolymphoid. So this is the DD. Again, always go back to the history. He was a 27-year-old man. It was in the pleura. The PET scan, which had been done earlier elsewhere, showed no other lesion. So first, straight off, because of the morphology, hematolymphoid, lymphoma or leukemia, we can get sarcomas in the pleura. So one must keep that in mind. Is it one of the undifferentiated small round cell sarcomas, either Ewing or the newer category? Is it a rhabdomyosarcoma? Is it a poorly differentiated synovial sarcoma? Less likely would be neuroendocrine carcinoma. Going purely by morphology, a lung carcinoma, mesothelioma is also unlikely, as are germ cell tumor and melanoma. So these are the responses we got on histology from the participants, all those who saw. And I'm happy to see that 17, the majority of them did call it hematolymphoid. Many called it non-Hodgkin lymphoma correctly because you really need to do further tests to subcategorize. 8 called it Burkitt lymphoma and 1 called it extramedullary plasmacytoma. 2 cases like you had in your differential thought of lymphohistiocytoid mesothelioma, which is a very, very rare type of mesothelioma which occurs. Others thought of a metastatic small round cell tumor, small cell neuroendocrine carcinoma, thymoma, and some infectious etiology. Now, the new history that I can give you is that this patient was HIV negative and was immunocompetent. So, will that affect your diagnosis? I just want you to think about it and I'll go on. So, again, just a little bit for the younger students in the audience, a starry sky appearance. I think that led to many of you calling this Burkitt lymphoma. But please remember that this is a feature of any rapidly proliferative hematolymphoid neoplasm. So, what is the sky? Those are the sheets of the malignant cells, which have large nuclei compared to cytoplasm. And the stars are the histiocytes, which are pale or clear, and they have the tingible bodies inside, which are actually the apoptotic debris of the cells that have necrosed. And this you see normally in a secondary follicle in the germinal center. So here, and they do the same job of phagocytosis of apoptotic tumor cells. So this feature can be seen in Burkitt lymphoma. It can be seen in T or B lymphoblastic lymphoma, in diffuse large B cell lymphoma, high grade B cell lymphoma. So any rapidly proliferative neoplasm can give rise to a starry sky appearance. So the first panel of IHC markers, CD45 LCA, CD99 MIG2, Desmin, PAN-CK, synaptophysin. We did think of hematolymphoid and morphology, but it is a good practice to always have a robust kind of variation of markers in the first panel. Now I'm going to show you the IHC pictures, and I want you to look at them carefully. CD45 was dead negative, as was desmin. Pan-CK was dead negative. Synaptophysin was dead negative. And now we have CD99 or MIC2, which shows diffuse moderate membranous staining. So, Priyanka, do we have a diagnosis now? Do we have to do something else? Can you answer in 1 second so we don't waste time?
Um, uh,
Okay, shall I go on if you have?
no, ma'am.
Okay, now I'll go on. So, this is TDT. And what does it show you? It shows you this diffuse, strong nuclear staining. Do you have an idea of what it is now? What it could be? Okay, I'm going on. So we go back to our story. The diagnosis of lymphoblastic leukemia or lymphoma was considered despite negative LCA, and the positive TDT that we got was a red flag. Now I must tell you that we actually did TDT in the first panel, though normally we would do it in the second panel because that was a very big DD. But once TDT came positive, we just had to subcategorize it further. So this showed it was a primitive kind of lymphoid proliferation. So we did CD3, CD20, CD10, PAX5 because it's a very specific B cell antigen for BALL. We did progenitor or immature markers like CD1A, CD34, and a KI67. Now I'm going to show you the pictures. So KI67 was very high, more than 95%. CD33 stained cytoplasmic diffuse strong. CD10 was moderate, diffuse strong cytoplasmic staining. CD1A also showed diffuse staining. Now CD20 negative, CD34 was negative in the neoplastic cells. You can see it highlights the vessels, and PAX5 was negative. So this is a summing up of the markers. Do you want to say anything now? What you think the diagnosis is? Priyanka,
Ma'am,
do you want to guess what the diagnosis is? I've shown you all the markers we had. Okay, so I'll go on then. So I really wanted to put in this picture of Arthur Haley's book, which he wrote in 1959, The Final Diagnosis. And this is because this is not a textbook of pathology, it's actually fiction. And he was a bestseller author. But in this book, the protagonist is a pathologist, which is not very common. It's a very interesting book, and I wanted to advise all of you to read this book. It's a work of fiction. Okay, so I'm going to the final diagnosis, which was T lymphoblastic leukemia or lymphoma NOS pleural biopsy. So once you have this, you're not sure whether it's leukemia or lymphoma. One has to look at the peripheral smear and the bone aspirate and biopsy. Here both were uninvolved. Cytogenetics was done. It was normal karyotype. The lumbar puncture was normal. The PET CT that was done now showed much more than the previous one. There was bilateral pleural effusion, there was pneumonitis, there was pericardial effusion, there were enlarged nodes, mediastinal, cervical, axillary, retroperitoneal. Now, why I brought this case is because a diagnosis of Ewing sarcoma had been made on this patient, and he had already received cycles of chemotherapy. But this, and there was some response because some of the chemotherapy markers are common to lymphoblastic lymphoma and Ewing sarcoma, but the drugs are actually different. So now he needed intrathecal methotrexate followed by high dose methotrexate. So the learning points from this case is that one marker positivity is insufficient to make a diagnosis. So just getting CD99 positive should not lead one to call this Ewing sarcoma. CD99 positive tumors are so many, and one of them is acute lymphoblastic leukemia lymphoma. There are other lymphomas also. So always a panel of IHC markers must be done. Never do just one or two markers. Again, just to show you that the TDT made all the difference. So once the TDT was positive, though the LCA was negative, we were able to put further lymphoid markers and come to the diagnosis. Another learning point is that we have lymphomas that are LCA negative. It's always good to know. So lymphoblastic lymphoma is one such, anaplastic large cell lymphoma, and plasmablastic lymphomas also can be dim and negative. And of course, the RS cells in Hodgkin lymphoma are usually CD45 negative. Another thing is that when one makes a diagnosis of a Ewing sarcoma or any of the undifferentiated small round cell sarcomas, one must back it up with molecular tests, and one can't depend on IHC alone. So the take-home message from this case, for all small round cell tumors at any site, need to do 2 or more panels of markers. Dangerous to stop when only one marker is positive in the first panel, especially when that marker is CD99, because you saw that whole list of cases where CD99 is positive. And remember that lymphoblastic lymphoma is very often LCA negative and CD99 positive. And so one must apply TDT or other immature markers early on in the panels. So to just have your antennae up, knowing that it can be LCA negative, but I want to do a TDT just to make sure I don't miss a lymphoblastic lymphoma. So I come to the end of my presentation.
You can continue.
Would have to go back to
Case
case
one.
one.
She's there. She's there.
Is the student Pooja ready for case one?
Yes, ma'am.
Okay.
I'm sharing the screen, ma'am.
We have stopped. And that's it. We will share. We have
Dr.
stopped
Pooja,
sharing.
please share
And
your screen.
Keep this ready.
The screen is visible, ma'am.
ours?
I want to see hers. I want to see hers.
We stop sharing.
Dr. Pooja, please share your screen.
We don't want to share it. So
They are sharing. No?
They are sharing. We want to see theirs.
Okay.
we are waiting for Dr. Pooja's screen.
Yes, ma'am. Shall I share my screen, ma'am?
Yes, please. Yes. Yes.
Please click on share screen and select entire screen.
Is my screen visible, ma'am?
Not yet.
Share screen, select entire screen, and then tap on the
Yes,
screen.
ma'am.
You have to tap on the screen first.
I have shared my screen, sir.
You have not yet shared. Click on share screen, select entire screen, and then you have to tap on the screen, then click on share button. Speak as you do the steps
Yes.
so that I'll be able to guide you. Click on share screen.
On to the next, please.
Select
Entire
entire.
screen I have selected,
Then
sir.
you tap on the screen. A screen is appearing. You tap on that. The share button will become blue. Click on that.
Yes.
Yes. Now open your PowerPoint and start your
Now
presentation.
is it visible, sir?
Yes. Slideshow mode. Put it on slideshow mode.
Yes. Shall I start now?
Yes.
Good afternoon, everyone. Myself, Dr. Pooja, second year postgraduate from Gulbarga Institute of Medical Sciences, Kalburgi. Our institute has been allotted case number 1 with a history of biopsy lung in a 36-year-old man, non-smoker. This is the whole slide image. It's having 5 tissue bits, and this is the region of interest. In this section, we can see the scanner view and the low power view arrangement of the tumor cells. Here the tumor cells are arranged in lobules which are separated by fibrous septate and solid nests and solid sheets. And this is a high power view of the tumor mass showing tumor cells. These are medium to large sized polygonal in shape with hyperchromatic nuclei, and few of the tumor cells are showing prominent nucleoli, and these cells also show peripheral palisading pattern of arrangement. Uh, and in this section, the low power view and high power view showing the alveolar spaces that are lined by type 2 pneumocytes, and these alveolar spaces are filled with inflammatory exudate. And in this section, we can see areas of fibrosis and this arrangement of tumor cells around the vessel wall, and also here we can see a normal lung parenchyma. In this section, we can see in the low power and high power view the epithelial pearls or keratin pearls. Also, we can see inflammatory cell infiltrate with the neutrophils and macrophages. Here in this section, low power view, high power view shows areas of necrosis, also a normal lung parenchyma, and a few of the alveolar spaces are filled with inflammatory exudate. And this is the high power view showing mitosis, the 1 to 2 mitosis per high power field we can see here. And considering all these microscopic features of the case, I come to the differential diagnosis. My differential diagnosis will be basaloid squamous cell carcinoma, large cell neuroendocrine carcinoma, keratinizing squamous cell carcinoma, and metastatic tumor. So, coming to the histomorphological features of each of these diagnosis, in case of basaloid squamous cell carcinoma, we will be seeing lobular nesting pattern of arrangement of cells with peripheral palisading, as seen in our in this case, and we can confirm the diagnosis with the IHC markers. They show diffuse positivity for P40 and negative for TTF1. And coming to large cell neuroendocrine carcinoma, even they show organoid nesting pattern, rosettes, trabeculae, and palisading pattern of arrangement of cells. But in this case, we did not see any kind of rosettes or trabecular like pattern of arrangement. Also, in large cell neuroendocrine carcinoma, squamous dysplasia will be absent. So I want to rule out large cell neuroendocrine carcinoma, as there is no squamous dysplasia will be seen in this in large cell neuroendocrine carcinoma. And coming to the IHC, these will be negative for P40 and positive for neuroendocrine markers like synaptophysin and chromogranin. Coming to keratinizing squamous cell carcinoma, they show squamous differentiation and keratin pearls will be seen, and also intracellular bridges can be seen, but basaloid cells will be absent in keratinizing squamous cell carcinoma. So I want to rule out keratinizing squamous cell carcinoma in this case, and they show diffuse positivity for P40 and negative for TTF1. And coming to metastatic tumor, uh, to diagnose it as a metastatic tumor, features the histological features should be consistent with primary malignancy. So the history of primary malignancy was not given. So I want to exclude metastatic tumor from the diagnosis. So Considering all the histomorphological features, my probable diagnosis would be basaloid squamous cell carcinoma. So features favoring basaloid SCC. Here, the tumor cells, they're arranged in solid sheets, nests, and lobular pattern of arrangement was seen with peripheral palisading of cells, and with the high mitotic activity, this is 8 to 10 per high power field, and also noted are keratin pulse and areas of necrosis. Thank you.
Doctor, can you stop sharing?
Yes, ma'am.
Go to the PPT second page. Second. No, no.
Case one, correct.
Am I audible?
Yes, ma'am.
Okay. Thank you, Pooja. I think that was a very good presentation. And you also
Thank
went
you, ma'am.
through it in a very orderly way. You had a very nice differential diagnosis slide put up. So I'm
Thank
just
you,
going
ma'am.
to give you a little more history. So he
Yes,
was a
ma'am.
young man. I think you must pay attention to the age also. He was a
Yes, ma'am.
36-year-old man. He had back pain, and the constipation was actually immaterial. He had a sigmoid polyp, but the CT
Yes, ma'am.
thorax showed a lesion in the lung, which was
Yes,
quite
ma'am.
a large lesion in the lung. He had mediastinal lymph nodes. He also had a lesion in the rib, which might have accounted for that pain that he had. The CT
Yes, ma'am.
abdomen showed lesions in the liver, which are likely to be metastatic. So he already had something which looks like a stage 4 disease.
Yes, ma'am.
So, okay, you showed your pictures very well. So, I'm really not going to accept that I have put an arrow to the keratinization. I think you focused a lot on the more undifferentiated looking cells. Just a
Yes,
point to keep that these were
yes,
seen. Another thing I would like to say is that really there is no peripheral palisading as such. If you look at the edge of the nests, they're not really palisaded. And another thing to notice is that in this area, the cells look fairly uniform. There is no
yes,
nuclear molding, and there is some sort of separation artifact in between the cells. Okay, just something to keep in mind.
yes, ma'am.
Again, the same thing, and we have entrapped pneumocyte marker. So if you did a TTF1, it would have stained these entrapped normal pneumocytes and may or may not have stained the other cells. So exactly as you said, nests of medium-sized cells that are relatively uniform, they're evenly spaced out. There is some separation artifact. There is no significant crush artifact as compared to the case two. There was not much of crush artifact, and there were foci of abrupt keratinization. So now, if we go back to a biopsy of the lung, when we think of primary carcinomas that have focal keratinization, as you very rightly said, a keratinizing squamous cell carcinoma, a basaloid squamous cell carcinoma, something called a nut carcinoma, a lymphoepithelial carcinoma can also have that, but it will have on morphology infiltration by lymphocytes and plasma cells that we didn't see in this case. And
Yes, ma'am.
adenosquamous carcinoma can have two components, one of which is squamous. And of course, combined large cell neuroendocrine carcinoma, which is a large cell neuroendocrine carcinoma with a component of squamous cell carcinoma. So I think all these are valid things to keep in mind. There are some others
Yes,
which may show squamous differentiation on IHC, but we will not consider that. And as you said, mets to the lung, always to keep that in mind if you don't have the history.
yes,
So I'm going to show you the IHC pictures. Please look at that. So we did limited IHC because in any biopsy of the lung, we don't like to use up all the tissue because we like to keep it for molecular studies. We did three markers. We did P40, TTF1, and synaptophysin. And what you see is P40, which is diffuse and strong. Almost every cell is stained. And TTF1 was negative in the neoplastic cells. And synaptophysin, which is a very sensitive neuroendocrine marker, that was also negative. So we know P40 is a squamous marker, P60 CK56, the high molecular weight keratins, they are squamous markers. So we go back to our differential diagnosis, right? So synaptophysin was negative. So we will rule out the large cell, combined large cell neuroendocrine with squamous carcinoma. Everything stained with P40. So there was no component of adenosquamous. Lymphoepithelial, we have kind of ruled out on morphology. We have ruled out the other things because they don't fit. So we are left with really three diagnoses: keratinizing, basaloid, and nut carcinoma. Okay, now these are the differential diagnoses submitted by the students who saw the pictures. Again, I'm happy to say that the majority, of course, they picked up the squamous cell carcinoma. Majority thought it was basaloid squamous carcinoma, like you did. Others thought it was keratinizing. One did not specify. A large number thought, because of those undifferentiated looking cells, that that was a large cell neuroendocrine with squamous cell carcinoma because of the pearls. Others thought it is a net with squamous differentiation. Someone thought of lymphoepithelial carcinoma. And that is not bad if you take the history that this was a young man and he never smoked. So this history is very important. One person made a diagnosis of nut carcinoma. And of course, adenocarcinoma was, it was not adenocarcinoma. Non-small cell lung carcinoma, when you have keratinization, you really need not say that. You can call it some type of squamous carcinoma. So the provisional diagnosis we made was a poorly differentiated carcinoma with squamous differentiation in the form of abrupt keratinization, biopsy lung. Now, we thought of this tumor, not carcinoma. It has abrupt keratinization in about 33% of cases. We wanted this to be excluded either by IHC, FISH, or molecular study, which could be RT-PCR or NGS, next generation sequencing. So again, very, very important, this young man had no history of smoking. And we know the usual squamous cell carcinomas, whether they're keratinizing, non-keratinizing, basaloid, they all have, in more than 90% of cases, they have a history of smoking. Now, our young man had no history of smoking, so we tend to think he might have some underlying molecular abnormality.
Yes.
So this case was sent for NGS, and this was comprehensive pan cancer NGS, DNA and RNA, which included all the relevant lung cancer genes also. And you can see here ALK and EGFR, which are the arrows, which might be seen to be mutated in squamous cell carcinoma. They are not detected. Instead, we have something at the bottom, which I will put in the next slide. So there was a fusion detected. I'm highlighting it here. So what was seen was a WHSC1L1, not M1 fusion. Now this WHSC1L1, the other name is NSD3. And this is described in cases of nut carcinoma. It's a rare fusion partner for nut M1. So now if you have not heard, you're a first year student, you may not have heard much about nut carcinoma. So I think we should talk about it. So it's a poorly differentiated carcinoma, genetically defined by the presence of nuclear protein in testis. So NUT stands for nuclear protein in testis. So there's a rearrangement of that gene. Earlier, this used to be called midline. That is not recommended anymore. And that is because though 92% occur in the lung, mediastinum, and kidney, which are kind of different sites, 8% occur in other parts of the body, like kidney, bladder, pancreas, thyroid, skin. And as more and more people are doing nut immunostaining or molecular tests, more and more cases are being detected in other parts of the body. So, since we did not do IHC and we do not have the nut antibody, I've taken this picture from this paper. So, the control would be normal testis, which is the only place where nut protein is seen in the spermatocytes. And the picture to the right shows a nut carcinoma, which would show a very characteristic IHC pattern. So this is called a speckled pattern. And this should be seen in more than 50% of the tumor cells. Now we know that NUT is seen in testis. So yes, germ cell tumors of the testis and actually ovary may show a little bit of staining, nuclear staining, but it is never more than 50%. It's usually 5%. It is faint and it doesn't show the speckled pattern. So this is a unique kind of staining that is seen only in nut carcinoma. Now the picture on the right is a fish picture using a break apart probe for this nut M1 gene. And you can see here, these are the broken apart um, uh, pictures, the red and green. And the most common fusion partner is BRD4, which is seen in 75% of cases. In 15%, it is BRD3. In 5%, the fusion is what we had in our case. So it's one of the rarer fusion partners, which is NSD3. So it is a very rare cancer. And in fact, these rare cancers have registries just so that they can collect cases from all over the world. So there is a carcinoma registry in Boston. So this tumor is a fairly new tumor, first reported in 1991 as a mediastinal thymic tumor. Even now, in the WHO book, it is listed under tumors of the thymus. So in India, we have less than 25 reported cases, and worldwide, there are less than 350. So this is a very, very rare case. And very clearly, on morphology, one can't diagnose this. One has to do it. I'm just reiterating that. So one has to do IHC staining or molecular tests. And it's important to do this because otherwise it's just going to look like a squamous cell carcinoma. So this is a very nice paper in 2025, very distinguished authors, Dr. Lester Thompson, Christopher French, Justin Bishop. So this is the group that have made the NUT registry. And they call this hiding in plain sight. So nut carcinoma is an unrecognized subtype of squamous cell carcinoma of the lungs and head and neck. So what you said was perfectly all right. You call it a squamous cell carcinoma. But one has to basically look for nut by doing the special things like the IHC or the molecular. So currently it is underdiagnosed. It's often misdiagnosed. So the main impact of this is that there is limited research and progress in developing effective treatments. This is one of the most aggressive forms of lung and head and neck cancer. So unless we start recognizing this more often in what looks like a very banal squamous cell carcinoma, we're going to miss it. And the patients will not get the treatment. So if we go back to our case, he received palliative treatment to the bone mets. Some chemotherapy was started, but because of the poor prognosis, he was discharged on request and for supportive care at home. And we have not seen him after that. But all the cases, none of them have survived more than 1 year. It's a rare tumor. It's the only thing that is available really are clinical trials with inhibitors. So I know you're a first year student, you made the right diagnosis, but this was going one step further to be aware of this tumor, which is probably hiding under our noses. We're not recognizing it, and why we need to work up these cases even more. So thank you, Priyanka. You did a good job. Thank you, Pooja. Sorry, you did a good job. And that's the end of my presentation. Okay, the take home is look out for abrupt keratinization on morphology. Have a high index of suspicion. Don't forget this nut carcinoma because it has all the squamous cell markers that you would want, but it needs specific IHC or molecular tests. Another small thing I wanted to say, any monotonous looking cells often have a gene translocation of fusion behind them, like the undifferentiated part of this look very monotonous. So that's a hint that there's an underlying gene fusion. And this holds good for tumors in any site that have an underlying fusion. So thank you very much. I'm going to stop my presentation.
Can we move on to case number 3? Can we have case number 3, Dr.
Yes, ma'am. Ma'am, can you see this slide? Hello, ma'am.
Yes, please put it in PowerPoint mode. Yeah, we can see your screen.
Good afternoon, ma'am. My name is Dr. Shankar. I'm a second year PG in Vaidehi Institute of Medical Science and Research Center. So my case history is 36-year-old female presenting with dyspnea, dry cough on and off since 6 months. A CT scan shows multiple tiny nodules in both lobes of the lung. Cell block of bowel fluid submitted. So coming to this is the slide. The H&E section of the bowel fluid cell block shows the presence of microlith, which is pointed by black arrow, or it is also called as calcospheroids. These microliths are basophilic, spherically concentrical, lamellated, refractile bodies. Here you can see which are interspersed between the alveolar macrophages, few lymphocytes, and few neutrophils. As you can see here, this black arrow. This is the macrophages, which has a round oval nuclei and well-defined cytoplasm and some carbon materials inside that. So, with the given history and this calcific congregations, and the patient is or has a history of dry cough since 6 months on and off, and the CT shows the multiple nodules of both lungs. I am of the diagnosis, it is uh, a pulmonary alveolar macrolithiasis, and my differential diagnosis are pulmonary corporoamalacia and metastatic calcification, which has a similar presentation, but it is distinguished by presence of a finely granular calcified calcium deposits in the metastatic calcification, and explaining a little bit about the pulmonary alveolar microlithiasis. It is a very rare autosomal recessive lung disease. Incidence in India is around 0.06 per million person. Throughout the world, there is reported 1,100 cases, and it is characterized by formation of tiny calcified stones or microliths within the alveoli of the lungs. And there is a genetic mutation that is seen in SLC34A2 gene, which is responsible for producing sodium phosphate co-transporter proteins, due to which there is a defect in this, and there is accumulation of the calcium, and there is formation of the uh, SLC34A2 gene is also found in other organs such as thyroid, salivary glands, mammary gland, uterus, testes, and the symptoms that normally we see is associated with shortness of breath, persistent dry cough, chest pain, and easy fatiguability. And on chest X-ray, we will be seeing the characteristic sandstorm appearance, where we have tiny nodules seen, which is given the sandstorm appearance. And in CT also, we find tiny nodules in both the lungs.
Which case?
3.
Case 3.
The video.
First slide.
Video on. Okay, hi. Dr. Afzal, you have done a very great job. So you have told all the points that I wanted to tell, and you have given the exact diagnosis which we made. So congratulations. So coming to the history, as I said, that was a 36-year-old female presenting with dyspnea and dry cough since 6 months, and CT showed multiple tiny nodules in both lobes of the lungs. The cell block of the bronchoalveolar lavage fluid was given. So you mentioned about the round spherical structures which were calcified. They're also called as microliths. You described them perfectly. And in the background, we see a lot of these alveolar macrophages. Okay. So we can do some special stains to highlight them. Can you tell me what are these two special stains?
Ma'am,
The
one
first
is
one?
Von Cosa, other
Okay.
one is Alzarin red district.
No, something easy stain, not so difficult.
Pass negative.
PAS, which is positive.
Positive, yes, sorry.
Okay. So the responses that we received were uh, sorry, it's echoing. One of you, please mute. Okay. So the responses that were received were a variety of ranging from sarcoidosis to LC, hypersensitivity, pneumonitis. Somebody called it calcified parasite, then hydatid cyst, pneumoconiosis, metastatic calcification, then pulmonary alveolar microlithiasis, and somebody called it even sclerosing pneumocytoma. Okay, so most of them are yes. Just by seeing the microliths in a BL fluid, we cannot directly jump into the conclusion of pulmonary alveolar microlithiasis. We have to consider all the other conditions that can cause secondary calcifications, especially infections like tuberculosis and inflammatory conditions like sarcoidosis. Metastatic calcification again is a very good differential. To get the characteristic spherules in the BL in metastatic calcification is difficult because this usually happens in the interstitium and in the vascular component. So it may not come out in the fluid. Okay, so and hydatid cyst again, it will be a lamellar membranous like structure and not the round spherules. And in melocoplakia, I think you got confused with the small Michaeli Gutman bodies. Those are usually small, but these calcified spherules are bigger. Okay, so we went ahead and they also sent the fluid for microbiological workup. So the AFB stain was negative, gene expert test was negative, so they excluded COX, and they sent to us to look for malignant cells which were not there. So we also called it probable pulmonary alveolar microlithiasis, and we suggested workup like to correlate with radiological findings and genetic testing. So you told almost everything. It's a rare autosomal recessive disorder characterized by intraalveolar accumulation of spherical calcified concretions, also called as calciferites, calcospheroids, or microliths, in the absence of any known calcium metabolism disorder. And one third of these cases are hereditary, having an autosomal recessive inheritance. So you also told about the sandstorm appearance. Very good. So in both the lungs, you can see multiple tiny nodules which are diffusely distributed. And the hallmark of this disorder is clinical radiological dissociation. That is, in spite of having such findings on radiology, the patient will not have very bad symptoms. They may present with just dyspnea and cough. So you also told about the mutation in the type 2B sodium phosphate cotransporter gene. So this occurs in this condition, and this causes excessive phosphate accumulation that may later act as a nidus for microlith formation. So it causes progressive loss of lung function, and the definitive diagnosis can be done only on genetic testing, or in cases if lung biopsy is possible. In such cases, you can see the microliths within the alveolar spaces, and they vary in size from 0.1 to 2.8 millimeter, and they are basically formed of calcium hydroxyapatite or carboxyapatite crystals. So histologically, they are positive for PAS, stain, and they are present within the alveolar spaces. So what these microliths do are they gradually grow into the alveoli and they fill the entire space, and they go and deep into the walls, and hence they exert pressure and cause damage to the walls, resulting in formation of fibrous tissue. So this is a micro. These are the findings of a child, 2-year-old child, who underwent a lung transplantation because of PAM, and this is the lung explant. On gross, you can see that there are multiple tiny gray white nodules, and this is causing accentuation of the interlobular septa because of the microlith accumulations. So these purplish bodies are the microliths, and as you described very well, there is a small central core-like structure surrounded by the concentric lamellated calcification, which are positive even on the von Kosa stain. So differentials, as we mentioned, rule out infectious conditions and metastatic calcification. And as I said, metastatic calcification usually occurs in the interstitium or in the vasculature and not within the alveolar spaces. You also mentioned about corpora amylacia as one of your DDs. Actually, I never thought of corpora amylacia. Yes, that is a good differential, but again, that occurs as a degenerative change in elderly, and this was a young patient, and we didn't think of this in our case. So there's actually no treatment drugs as such which have been proven effective for such for cases of PAM. The only effective therapy is lung transplantation. Recently, a drug has come out which is disodium etindronate, which has been used to treat PAM with mixed results. It inhibits the formation of new pulmonary calcium phosphate crystallization, and it resolves the previously formed calcification, and hence thought to help in such cases. And the long-term prognosis is poor because of progressive deterioration in pulmonary function, causing respiratory failure and finally cor pulmonale. So this was a case of probable pulmonary alveolar microlithiasis, and the patient has been referred to a higher respiratory center for management. Okay. Thank you. Good work, Dr. Afzal. Okay, case number 4, Dr. Kausalya.
Yes, ma'am.
Ready? Yeah, please start.
Can I start, ma'am?
Yes, please. Please make it full screen in PowerPoint mode. Okay. Thank you.
Yeah.
Please start.
Yeah. Case allotted to me is case number 4, and I am a second year junior resident from Kidwai Memorial Institute of Oncology. The case history which was given to me is a 11-year-old female who presented with chest mass. An X-ray showed a large expansile lytic lesion which was arising from the left third rib, and a core biopsy from the mass was provided. On the scanner view, you can see a section which shows multiple cores of tumor tissue with cores of fibrocollagenous tissue, and a highly cellular lesion composed of population of large number of osteoclastic giant cells between plump spindle to oval cells. And here, oval to plump spindle stromal cells, which were having ill-defined cell membrane with pale eosinophilic cytoplasm and nuclei exhibited open chromatin pattern, and osteoclast-like giant cells, which had variable number of 20 to 30 nuclei. And few of the hypercellular areas showed fascicles of oval to spindled hyperchromatic cells which exhibited mild to moderate pleomorphism with occasional mitosis as shown here. And yeah, these were the few mitoses that we noted, and also atypical mitosis were seen, few apoptotic bodies, and permeative areas with entrapped bony spicules were noted, and cyst-like spaces lined by numerous osteoclastic multinucleated giant cells, and a fibrocollagenous cyst wall, which again was lined by osteoclastic giant cells, and few areas showed hemangiopericytomatous pattern, and few osteoblasts were noted, which were eccentrically placed nuclei with moderate cytoplasm. And here, these are the few of the cyst spaces lined by osteoblasts, which can be the new bone production. And hemosiderin-laden macrophages were also noted. And pink like eosinophilic areas, query osteoid. And summary is a giant cell rich neoplasm, osteoclastic type, aneurysmal bone cyst like changes with solid component, and hypercellular spindle cell areas with mild to moderate pleomorphism, areas of 4 to 5 mitosis per hyperfill in hotspot areas with occasional atypical mitosis, and query lace like osteoid, and there was no obvious necrosis or high grade nuclear features noted. The possibilities which were considered were ABC, solid subtype, and osteosarcoma with secondary aneurysmal bone cyst-like changes should be ruled out, and GCT with secondary ABC-like changes, and to rule out a brown tumor of hyperparathyroidism. So my diagnosis was giant cell-rich neoplasm with solid aneurysmal bone cyst-like areas, third rib, lesion biopsy. In view of atypical mitosis and lace-like area, osteosarcoma should be excluded and to be correlated with radiological details. And the points in favor of the ABC solid subtypes are these osteoclastic giant cells which lining the cyst wall and extensive spindle cell proliferation. The points against it were absence of blood-filled cysts. For osteosarcoma, the points in favor were thin lace-like osteoid, occasional atypical mitosis, and mild to moderate pleomorphism. Points against was the occasional mitosis and absence of high-grade nuclear features. And giant cell tumor with secondary ABC-like areas. Points in favor were spatial distribution of giant cells, solid type of ABC-like area. Points against were location, that was flat bone, which normally occurs in 20 to 40 years of age group. For brown tumor, the points in favor are osteoclastic giant cell lesions, and against we have absence of hemorrhage, and there were very few hemosiderin pigmented macrophages. So IHC and molecular tests that could be done for ABC was USP6 rearrangement. For osteosarcoma with secondary ABC-like areas, SADB2 positivity is seen, osteoclastin positivity in high Ki67. Giant cell tumor with ABC-like areas, you have HF, H3, F3A, G34, W positivity. And for brown tumor, you have to see the elevated serum PT, parathyroid hormone levels. Thank you.
Okay. So, Dr. Kausalya, what was your final diagnosis? Dr. Kausalya, can you hear me?
Yes, ma'am. Yes, ma'am.
What was your final diagnosis?
Ma'am, giant cell rich lesion.
Okay.
With giant cell rich lesion, rich neoplasm with solid aneurysmal bone cyst like areas.
Okay. Okay. Okay.
And in view, because of view atypical mitosis and lace like areas, like osteosarcoma should be excluded.
Okay. Okay. So very good presentation. You have covered many of the points and shown many of those findings which are relevant to the case. So I'll go on with the discussion. So 11-year-old female presenting with a chest mass. An X-ray showed a large expansile lytic lesion arising from the left third rib, and a core biopsy from the mass was submitted. So this was the mass lesion. On CT scan, you can see that there is a large heterogeneously enhancing expansile lytic lesion occupying the entire left hemithorax arising from the left third rib, and it measured about 18 centimeter in the greatest dimension. And this was after resection. This is the gross photo of the same, where you can see that it's a large lobular mass and it is showing many cystic spaces filled with hemorrhage and fluid like material, and also a lot of solid areas which have this shiny gelatinous like appearance. So now what do you think this is after seeing the gross photo?
Ma'am, after seeing the gross photo, giant cell tumor, ma'am.
After seeing the cystic spaces?
ABC.
Okay. Okay,
Solid
great.
ABC.
Okay, so solid ABC. Okay, great. Now you made the diagnosis. So this is the core biopsy. Here you can see that, as you mentioned, there are a lot of giant cells, as well as there is a lot of fibrous stroma with proliferation of fibroblasts. And you also mentioned that the giant cells are not uniformly distributed, which is a very good observation. You also mentioned the HPC like vasculature, as you can see in this case. Then we could see the vascular spaces on higher power and a lot of areas which had this fibroblastic proliferation. And there was a lot of new bone formation as well. This is the resection specimen, the whole mount image, where you can see that there are a lot of solid areas and there are a few cystic spaces which are filled with blood. And this is the inked outer surface, and we can see a lot of new bone formation, and this is the lesion. Okay, so this is post treatment. What do you think this is? There is a vessel and something which is popping into it. What do you think this is post treatment?
Is it
This one, this one. Okay. So this is actually neovascularization which is happening in the cystic vascular spaces. There is new bone formation, and again cystic spaces filled with blood, and lot of these giant cells which are not uniformly distributed. They are osteoclast like giant cells. And again, look at the background stroma. The stroma is not looking like a giant cell like, because in giant cells the neoplastic cells is the are the stromal cells or the osteoclastic giant cells in a giant cell tumor.
stromal cells, ma'am?
Yeah, so the stromal cells are the neoplastic cells in a giant cell tumor. So here it is not prominent, and the nuclei of the stromal cells should look like the nuclei of the giant cells. In this case, it is not looking like that. Okay, and the giant cells are haphazardly distributed; they are not uniform. And this is again post treatment. What treatment do they give for a giant cell tumor? Something.
Densinamab.
Yeah. So denosumab induced changes. So there is a lot of fibrosis and sclerosis and lot of new bone formation. That was what you were saying about the osteoid, correct? And you mistook the osteoid for a malignant osteoid and thought it may be an osteosarcoma. So it was actually a reactive osteoid. There is no malignant osteoid. Yes, there is a lot of new bone formation which can occur in ABCs, but again, it's not the malignant lace-like osteoid. This is the reactive osteoid, which is slightly thicker. And you mentioned about atypical mitosis. Yes, they can be seen in ABCs, but there are no pleomorphic cells to look for as in osteosarcoma. Okay. So the responses that were received were GCT, solid ABC. Many of you made the diagnosis. Then, because of the areas with lot of fibroblastic proliferation, many called it solitary fibrous tumor. This was in our back of our mind also. Then again, osteosarcoma, yes, because it's a child, and the first thing the pediatric oncologist will think of is osteosarcoma and Ewing sarcoma, which also clinically it is a good diagnosis. So this was a case of a solid aneurysmal bone cyst. So IHC will not help much in this. It's basically to rule out the other differentials, okay, in the pediatric age group. So SMA was positive, and Ki67, that is the proliferation index, was around 20%. And we also did other markers, and pancytokeratin, desmin, CD34, STAT6, EMA, and TLE1 were negative. So basically, we wanted to rule out SFT and synovial sarcoma as well. And in the child, we wanted to rule out Ewing sarcoma as well as RMS. So that is the basic panel that you will do in a pediatric population. Okay, so ABC is a benign neoplasm of bone containing multiloculated blood-filled cystic spaces. So usually arises from the metaphysis of long bones, especially the femur, tibia, and the humerus, and can also occur in the vertebral bodies. So basically, the signs and symptoms will be because of fracture, causing pain and swelling, and usually occurs during the first 2 decades of life, and males and females are equally affected. So on radiographs and CT presents as a lytic expansile lesion with well-defined margins. So MRI has the characteristic fluid levels because of the different signal intensities of the cyst contents. Okay, and on bone scan it can show increased peripheral radiotracer uptake because of the reactive bone formation. So you also mentioned about the USP6 gene rearrangement, which occurs in chromosome 17p13.2, and the most common translocation is T1617, resulting in fusion of CDH11 with USP6, resulting in upregulation of USP6 transcription. So this rearrangement is found in about 70% of ABCs, but not in ABC-like changes in other tumors. So Dr. Kausalya, what are the other tumors where you can see ABC-like changes? You mentioned.
Osteosarcoma, yes, ma'am. Osteosarcoma and giant cell tumor.
Okay, okay. One more tumor which has the chicken wire-like
Chondroblastoma.
chondroblastoma. Yes, in chondroblastoma also you can see secondary ABC-like areas. Okay, so grossly we already described it, and this is the photo of a fish showing the USP6 gene rearrangement. There is a split of the red and the green signal. Okay, so WHO mentions that essential criteria for ABC is multicystic lesion with fluid levels, cyst wall composed of fibroblasts and osteoclast like giant cells, and newborn formation, and desirable if you can demonstrate the USP6 gene rearrangement. So differentials we mentioned: giant cell tumor, osteoblastoma, chondroblastoma, and osteosarcoma. So the WHO doesn't recognize the solid variant as a distinct subtype. So it was first introduced by Sankara et al. In 1983 to describe cases which had predominantly solid areas on histology. Okay, and you also mentioned about this histone protein, which will be positive in the giant cell tumors and negative in the ABCs. So it's a locally recurrent neoplasm with recurrence rate of about 20 to 70%. Okay, so in this case, after a multidisciplinary tumor board discussion, the patient was given denosumab treatment and followed by surgical resection, and there was a good response to denosumab. We saw that there was a lot of sclerosis. I showed you the photos, and there was reduction in the giant cells, and there was newborn formation. Now the child is doing well, 16 months post surgery. So I gave this case because diagnosing ABC, especially on core biopsy, is challenging, and especially in the pediatric age group where the clinician usually thinks of other common tumors like Ewing sarcoma and osteosarcoma. And rib as a site of origin for an ABC again is very rare. So without extensive radiological assessment, this cannot be determined, and a comprehensive panel of IHC markers along with morphology is very much important to rule out the other differential mesenchymal neoplasms. Okay, so thank you. A good presentation, Dr. Kausalya.
Thank you, ma'am.
Dr. Nabanita, are you ready with case number 5?
Yes, ma'am. Good afternoon.
Can you be louder, please?
This is Dr. Nabanita. I'm second year postgraduate from Yenapaya Medical College. The case allotted. Yeah.
Doctor, your screen is not visible. Have you shared your screen?
Yes, I'm trying.
We are not able to see your.
Is it visible now, ma'am?
Yes. Yes, please go to PowerPoint mode.
Nabanita, I think just a minute. Please stop sharing.
Okay.
Now, click on share screen and select entire screen.
Yes. Is it visible now?
Yes, go ahead.
Okay, thank you. This is Dr. Nabanita. I'm second year postgraduate from Yenapaya Medical College. The case allotted to me is case number 5. The history provided, a 29-year-old female came with complaints of loss of weight and appetite and cough. CT chest shows right lung with upper lobe heterogeneously enhancing mass lesion measuring 13 into 10 to 7.5 centimeters with multiple mediastinal and supraclavicular lymph nodes. Endobronchial and transbronchial lung biopsies are done. Uh, I have been given two slides. First slide is slide 5A, where we can see under low power multiple tissue cores. Under medium power, uh, under 4S, we can see one tissue core where we can see dense inflammatory infiltrate. Coming to the medium part, we can see there is a blood vessel and dense infiltrate of lymphoid cells, which indicates that the wall of the blood vessel being destroyed and necrosis can be seen. Coming to the higher part, we can see there are atypical lymphoid cells which are large in size and with large nuclei and irregular nuclear borders and scant cytoplasm. Adjacent area again shows blood vessels and dense mixed inflammatory cell infiltrate. Though not a well-known granuloma, but there is a collection of histiocytes. Again, one field shows dense mixed inflammatory cell infiltrates composed of lymphocytes, neutrophil plasma cells, and few eosinophils. There are few typical lymphoid cells which resembles to RS cells, which I have marked. The slide B shows here we can see parenchyma under low power. Another field shows dense inflammatory debris and crush article. So, summarizing my findings are the lung parenchyma, sheets of macrophages admixed with inflammatory cells composed of lymphocytes, plasma cells, neutrophils, eosinophils, typical lymphoid cells, and few like cells, and angiocentric and angiodestructive polymorphous lymphoid infiltrate and necroinflammatory debris. With these findings, I have two differentials, lymphomatoid granulomatosis, and second is Hodgkin's lymphoma. The reason behind lymphomatoid granulomatosis are polymorphous lymphoid infiltrate with striking angiocentricity, transmural involvement of small to medium-sized blood vessels by lymphoid cells. So, lymphomatoid granulomatosis is a probable diagnosis, and the other DD is Hodgkin's lymphoma due to presence of RS-like cells in an inflammatory background, and a good number of eosinophils also favors the diagnosis of Hodgkin, and lymph nodes are involved, but since non extramural Hodgkin's in lung is very rare, I have ruled out this, whereas lymphomatoid granulomatosis is most common in lung. So, by probable diagnosis is lymphomatoid granulomatosis. We can rule out with the help of immunohistochemistry CD45 is positive in case of lymphocyte dermatosis and CD45, CD20 are positive in case of lymphomatoid dermatosis, whereas negative for classical Hodgkin's lymphoma, and CD15 and CD30 both are positive in case of Hodgkin's lymphoma, but CD15 is negative in case of lymphomatous granulomatosis. These are my reference. Thank you.
So thank you, Dr. Navanita. That was a good presentation and a good differential diagnosis. So we have come to a crossroad between two diagnoses you just made. So I'm Dr. Divya from Shankara Cancer Hospital. So I would like to discuss two cases today. Both of these cases, we came to a crossroads where we were finding it difficult to come to one diagnosis, and so we'll see how we approach these cases. So as you presented, so this was a 29-year-old female whose slides came to us for review. So we had two slides. One was a CT guided core needle biopsy from the right lung lesion, and the other was a transbronchial lung biopsy of right middle lobe lung. Now, the history given was PET-CT showed complete collapse consolidation of the right lung, and there was a mass lesion with high SUV, and the size of the mass lesion was almost 13 centimeter. There were also multiple enhancing mediastinal and right supraclavicular lymph nodes. However, there were no other lesions or no other lymph node groups which were involved, and bronchoscopy also had an endobronchial component. So this was slide A and slide B, which were received for review. Now, as you discussed, so the course of tissue showed a dense mixed inflammatory cell infiltrate, which was particularly dense in the transbronchial biopsy. So both these showed similar morphology, except that inflammation was denser in the transbronchial biopsy. The inflammatory population comprised of, I would say, small lymphocytes. There were plasma cells. There were eosinophils. There were a lot of these epithelioid histiocytes, which were forming ill-formed granulomas, little well formed in some places. There were areas of necrosis like this, but even in low power, one could make out the scattered large cells which looked multinucleate at places and irregular nuclear membranes. They had prominent nucleoli, so the typical HRS like cells were seen. And the similar findings were seen in the transbronchial biopsy as well. So there was a dense mixed inflammatory population with epithelioid histiocytes and lymphocytes. Epithelioid granulomas with necrosis was seen, and scattered HRS-like cells were seen. So the morphological diagnosis. So these were the responses we received. Classic Hodgkin lymphoma was the most common diagnosis made. We had other diagnoses like this: desmoplastic small round cell tumor, inflammatory myofibroblastic tumor, pulmonary LCH, which is also a good diagnosis, CMV associated pneumonitis, and interstitial pneumonitis due to leishmaniasis, which are particularly rare, and then other carcinomas. Now, this image is that of a similar lesion which may have a polymorphous population with these grooved histiocytes. Can you make a diagnosis on the slide?
LCH, Langerhans cell history.
Yes. Yes. And what is this marker which comes positive in LCH? It is
CD
CD. Yes. CD.
1A.
CD1A, Langerhans. Now, what is this lesion, which is also common in the lung, which can present with a polymorphous inflammatory infiltrate? But there are also spindle cells, as you see here, along with these scattered large cells with prominent nucleoli. Can you make a diagnosis on this slide?
Inflammatory myofibroblastic tumor.
Yes. So, what is this marker, which comes positive in inflammatory myofibroblastic tumor? Okay, it's ALK. Now, this is just a picture of CMV. Hello, is my screen visible?
Yes, ma'am.
Dr. Navanita?
Yes, ma'am. It's visible, ma'am.
Dr. Navanita, can you hear me?
Yes, ma'am. I can hear you.
Okay. So this is a case of CMV pneumonitis, which is particularly rare, and we will think of this diagnosis only in the context of an immunosuppressed individual, which in this case was not the case. So I would like you to interpret, Dr. Navanita, if you are available. Can you interpret the IHC? Now this is CD20, which was done on the same slide, the core needle biopsy from the right lung mass. Okay, I can't reach Dr. Nabanita. So this is CD20, and as we see here, they are staining the B lymphocytes, which are the small B lymphocytes here. We can identify the large cells here, which are not stained. This is a higher power view. Here, we can clearly see that the large large lymphoid cells are not stained by CD20. Now, this is a photomicrograph of PAX5, we can identify the large cells here, which show dim positivity. There is variable staining. There is staining of moderate intensity as well as very weak staining in the large atypical lymphoid cells, whereas the background small B lymphocytes show strong staining as seen here. I hope you can identify the dim staining by PAX5. These are the other immuno IHC markers we did. So CD3 is staining the rich T cell population in the background, whereas these large cells are not stained. CD79A, here we can see it's a B cell marker which is not staining the large cells, whereas the small B lymphocytes in the background are stained by CD79A. Now CD15 is showing weak to moderate staining of these large cells. This is CD30, which is showing strong cytoplasmic membrane staining of the large atypical lymphoid cells. EBV LMP1 was not contributory. I mean, we couldn't appreciate very good staining. Whereas EBERISH, which was done on the same slide, showed strong nuclear staining of the atypical lymphoid cells. So we come to a diagnosis where we have a lymphoproliferative disorder where the B cell program is downregulated, which is made out by dim negative CD20 and CD79A and dim staining for PAX5. And the same cells are positive for CD30 and 15, and the cells are also staining for EBERISH. So it is an EBV associated lymphoma. Dr. Navanita?
Yes, ma'am.
Okay. So we had come to a crossroad between classic Hodgkin lymphoma, lymphomatoid granulomatosis, and a possibility of an EBV positive large B cell lymphoma. So at the end of our IHC panel, we came to a diagnosis of classic Hodgkin lymphoma, mixed cellularity type of the lung mass. But I would like to ask Dr. Navanita, like how is this presentation of a large lung mass with minimal lymph node involvement? Is this the common presentation of a classic Hodgkin lymphoma? So classic Hodgkin lymphoma most commonly involves the anterior mediastinum, especially the thymus, and as well as other lymph nodes. Secondary pulmonary involvement occurs in 12 to 40% of Hodgkin lymphoma, usually because of extension of disease from the mediastinal or hilar lymph nodes. But the primary pulmonary Hodgkin lymphoma represents lymphoma which directly arises from lung tissue, and this is very rare, comprising less than 1% of all lung cancers. Kern et al. Proposed this following criteria for diagnosis of primary pulmonary Hodgkin, where histological features of Hodgkin lymphoma are identified. There's a restriction of the disease to the lung with or without minimal hilar lymph node involvement, and adequate clinical and or pathological exclusion of disease at distant sites has been done. So in our case, a PET-CT scan was done, which showed involvement of the hilar nodes as well as supraclavicular lymph nodes, apart from the large necrotic lung mass. So, though we cannot conclude that this was a primary pulmonary Hodgkin lymphoma, we would say that it is possibly likely. Now, classic Hodgkin lymphoma is most often associated with EBV. I would encourage all the postgraduate students to be familiar with the latency patterns of EBV. So, EBV may persist as an integrated fragment or as a defective genome. In these conditions, the EBV positivity cannot be demonstrated. So, because it is type 2 latency in classic Hodgkin, we know that LMP1 as well as EBERISH are expected to be positive, but sometimes they may not be stained by conventional techniques. Now, HRS cells are germinal center B cells with a down-regulated B cell program, because of which the B cell markers are weak to absent. So, as you all know, I would like you to identify this image. So, this is a subtype of Hodgkin lymphoma where there is classic nodularity surrounded by fibrous bands, and we have this lacunar type of RSLs. This is the nodular sclerosis type. The nodular sclerosis type of classic Hodgkin lymphoma is the most common subtype seen in the mediastinum. Now, these are the collagen bands which are seen between the nodules. These are the HRS cells. This is a mixed cellularity type of classic Hodgkin lymphoma with the HRS cells. This is prominent new eosinophilic nucleoli. Now, because of this inflammatory infiltrate and presence of fibrous bands on a core needle biopsy, making a diagnosis may be particularly difficult. And classic Hodgkin lymphoma may present as necrotizing granulomatous lymphadenitis in 1 to 1.8% of cases. And this presentation as such is rare. We know granulomas do occur, but necrotizing granulomas are rare. And cases with dominant fibrosis and rare neoplastic elements may present a diagnostic challenge, especially in core needle biopsies. So the most useful markers for HRS cells, are CD30 and CD15, which are present in 100% and 75% of cases respectively. So this is CD30, CD15, this is CD20, which is negative, PAX5 is dim. So the other markers which are expressed are MUM1 and FASN. LMP1 is expressed in EBV positive cases in 10 to 25% of nodular sclerosis, classic Hodgkin lymphomas. CD45 ALK and EMA are negative. PDL1 expression is activated by genetic alterations and represents a potential therapeutic target. The background shows a rich CD4 plus T cell population. So prognosis is poor, especially for primary Hodgkin lymphoma. I mean, the data is not available. However, presence of B symptoms, bilateral disease, multilobular involvement, penetration of the pleura, cavitation, age over 60 years, and clinical relapses are the poor prognostic factors. So the common DDs are lymphomatoid granulomatosis. We know it's an EBV associated B lymphoproliferative disorder, which also has a prominent T cell infiltrate. This lymphomatoid granulomatosis involves lung in all cases, and lymph node involvement is rare. So our case had mediastinal as well as supraclavicular lymph node, and they say if the lymph nodes and or bone marrow involvement is present, must suggest an alternative diagnosis. And the etiology is because of immune suppression. Diminished immunity, especially decreased cytotoxic CD4 plus T cells, leads to an abnormal host immune response to EBV and leading to development of this condition. Now, clinically, it may present as a solitary cavitary lung lesion or as bilateral basal lobe lesions in the lung or even as with an interstitial pattern of lung involvement. Now, on histomorphology, it shows a similar polymorphous lymphoid infiltrate we saw earlier, mixed population, scattered large cells. Now, what is striking here is the angiocentric distribution. So, we must identify the vessels and there is transmural involvement of these arteries by the small T lymphocytes, and there may be RS-like cells. Necrosis is common because the vessels are involved, and the background will show a T cell population very similar to our Hodgkin lymphoma. However, well-formed granulomas are generally absent. Now, ISC helps in diagnosis and helps in differentiating it from the classic Hodgkin lymphoma. We see strong staining for the B cell markers. So, all these large cells are stained by CD20 and the background population is CD3 positive. Eberish is also positive in this case. Now, this grading of lymphomatoid granulomatosis is important from a treatment point of view. So, grade 1 has very few EBV positive large cells. Grade 2 has 5 to 50 per high power field of these large EBV positive cells, and necrosis is common. In grade 3, we see a lot of necrosis like this and more frequent EBV positive cells, more than 50 per high power field. However, if we see a uniform population of large atypical cells, then the diagnosis of an EBV positive large B cell lymphoma is more appropriate. The prognosis is variable, especially in grade 3 lesions. The survival is poor. The second DD would be an EBV positive large B cell lymphoma, which may present, which is also EBV driven, and it has a lot of these CD20, PAX5, CD79A positive large cells, and EBV is positive in the majority of these large cells. However, one must be important, make sure that there is no immunodeficiency or no history of lymphoma, and other EBV related lymphomas and lymphoproliferative disorders should be excluded. It may occur in younger patients and often show nodal involvement. This nodal involvement is not a feature of lymphomatoid granulomatosis. Now, it has two variants. There's the polymorphic variant, which resembles classic Hodgkin lymphoma, and there's a monomorphic variant, which resembles DLBCL. The immunophenotype is there is strong diffuse positivity for the B cell markers CD20 and PAX5, and they show high Ki67. They're positive for both LMP1 and Eberish, and this is a dual staining by CD20 and Eberish. So the prognosis is poor in this case. So thank you, Dr. Navanita. You saw how IHC helped in diagnosis of this case, without which we would have been at a crossroad between lymphomatoid granulomatosis and classic Hodgkin lymphoma. So the patient is on follow-up, and let's move on to the next case.
Thank you.
Dr. Purnika. Dr. Purnika.
Is the next presenter available?
Can we move to case 6, please?
Ma'am, I'm ready, ma'am. Hello, ma'am. Am I visible, ma'am?
Share screen. Entire screen. Click on that. Share. Check your video. Ask them, is my screen visible?
Ma'am, my screen is visible, ma'am.
You are muted, I think.
You're audible, Purnima. Purnika, go ahead. You're audible.
Okay. Thank you, sir. Good afternoon, everyone. I am myself Dr. Purnika Devi from Bangalore Medical College and Research Institute. I'm second year postgraduate. Today, I am going to present
Dr.
KCIAPM.
Purnika, I cannot hear you.
Ma'am, no, okay, am I audible
Can
now,
you
ma'am?
just hold on 1 minute? We will check at our end. But till now it was not. Yeah. I do from there.
Purnika, you're audible. Don't make any changes there.
Okay, ma'am. Okay, sir. Sir, can I start, sir?
Hello, can you hear us?
Yes, ma'am. I can hear you, ma'am. Can I start now, ma'am? Ma'am, am I audible to you, ma'am?
Just wait. Purnika, I think they're not able to hear you. Just wait.
Okay, sir. Okay. Ma'am, can I start present, ma'am?
Dr. Purnika, don't make any changes. Stay where you are. Just open a slide and wait there. Okay.
Okay, sir.
Sir, can you hear us now?
Ma'am, am I audible to you, ma'am?
Yeah, yeah, we can hear you also. Yes.
Okay, ma'am.
The
Shall I
presenter
continue?
can start. Yeah.
Okay. I'm Dr. Punika Devi, ma'am, from Bangalore Medical College, second year postgraduate. Today I'm going to
Go
present
on.
KCIAPM slide, case number 6. The history given was 56-year-old male came with a complaint of fever for 2.5 months, and CT chest showed a 7 cross 8.6 cross 6.5 cross centimeter lesion in the left upper lobe of the lung with mass effect on the subsegmental bronchopulmonary division. CT guided biopsy of the lung mass was given. The slide given to me shows multiple cores of tissue, that is four cores of tissue it was shown. On scanner and hyperview, those four cores of tissue shows presence of tumor cells in each of them. On higher magnification, the core tissue shows spindle cells are arranged in fascicles, and some of the spindle cells are bizarre looking and showing marked pleomorphism in each of the cells, and few of the cells are looking polygonal shaped, and individual tumor cells are showing high NC ratio with marked hyperchromatic nucleus, and few of the cells showing prominent 1 to 2 nucleoli, and they are having abundant granular eosinophilic cytoplasm. And still going to higher power, we can still able to visualize the marked pleomorphic spindle shaped cells. On going to higher power, again we can appreciate some multinucleated tumor giant cells, and a few frequent mitosis also we can be able to note it. And on background we can see inflammatory cells also, lymphocytes and neutrophils. So coming to the microscopy, section studied from the multiple core biopsy shows presence of tumor cells and no normal tissue were found. Tumor cells appears highly pleomorphic, composed of spindle to round cells noted. Individual tumor cells are large with marked nuclear pleomorphism, bizarre looking spindle cells, hyperchromatic nucleus with abundant granular eosinophilic cytoplasm. Few of these cells was occasional nucleoli. Frequent mitosis noted, many multinucleated tumor giant cells with few inflammatory cells composed of lymphocytes and neutrophils are noted. No necrosis or hemorrhage are seen. Uh, my possible DDs are pleomorphic sarcoma and sarcomatid carcinoma. It is a vague DD of pleomorphic carcinoma. I would like to go with the IHC panel to subtype the pleomorphic sarcomas. So my first differentials for pleomorphic sarcoma, I can go with rhabdomyosarcoma, where the histological features show large cell with eccentric nuclei and deep eosinophilic cytoplasm. For IHC, it will be myogenin positive and myod positive. For malignant fibrous histioma, in histology, we will see hypercellular and composed of spindle-shaped or epithelial or polygonal cells with marked polymorphism arranged in soriform or fascicular pattern. Here we can do with vimentin positive, and CD34 will be variable and desmin will be negative. Coming to malignant peripheral nerve sheath no-sheath tumor, spindle cells with hyperchromatic, thin, wavy or focally buccal nuclei, and mixed-site stroma and hyalinization are noted. Here we can go with extended will be positive for malignant peripheral nerve sheath tumor. Coming to pleomorphic liposarcoma, the prominent pleomorphic lipoblastic cell with paculated cytoplasm and scalloping of the nucleus will be seen. For IHC, ascended positive and SMA will be positive and vimentin will be positive. Coming to sarcomatide carcinoma, here we can see the sarcomatas and carcinomatous components within it, and for that IHC will be cytokeratin will be positive, ascended will be positive, or desmin will be positive, and vimentin will be positive. Thank you.
Thank you, Dr. Purnika, for the detailed presentation. So let us see how we approach this case. So 56-year-old male came with complaints of fever for 3 months, and there was a large lung mass which was detected in the left lower lobe of lung, compressing the segmental bronchopulmonary divisions. So we got the CT guided biopsy. So you have given a beautiful description. So I will just proceed to go and show you more images from different areas of these pleomorphic, bizarre appearing multinucleate cells with brisk mitotic activity. They're spindly to epithelioid, and overall they show a very pleomorphic appearance. So epithelioid to spindle cells, bizarre nuclear atypia, and multinucleate giant cells are seen. So on morphology, these were the responses received: metastatic lung disease, undifferentiated pleomorphic sarcoma, rhabdoid tumor, anaplastic large cell sarcomatoid giant cell carcinoma, histiocytic sarcoma, high-grade spindle cell sarcoma, carcinosarcoma, anaplastic large cell lymphoma, PCOMA, and inflammatory pseudotumors. So coming to correlation of the histomorphology with the IHC. Let us see how the markers were staining. So this is pancytokeratin, which is completely negative. The cells were positive for vimentin diffusely. A CD68 and CD163, which are histiocytic markers, were showing diffuse, moderate to strong staining, showing that there was a large component of cells which were positive for histiocytic markers as well. Melan A, however, was negative. S100 showed strong cytoplasmic and nuclear staining of the large cells. It was patchy but quite strong. Now, because S100 was positive and melanine was negative, we still wanted to exclude a melanoma, so we did HMB45. Now, HMB45, though it was staining a few cells, it was not diffusely staining all of the atypical cells. So again, we came to a crossroads again for between a diagnosis of a pleomorphic sarcoma, a histiocytic sarcoma on one side, and melanoma on the other side. So at this point, Dr. Kumar, would you like to ask the clinician about any relevant history? Okay, so this was a crossroads. So the patient had history of right grade toe amputation, which was revealed to us only after asking. So this was which they had a report of a pleomorphic sarcoma of right toe, which was amputated about 2.5 years back. But the slides were not available for review. Now, as the diagnosis was pleomorphic sarcoma, which was given on histology with no IHC, we still wanted to exclude a diagnosis of a acral melanoma. So the ISC panel we did showed tumor cells which were immunopositive for vimentin, CD68, S100, HMB45, which was only in 10% of cells, and focal H-caldesmon. The tumor cells were immunonegative for pancytokeratin, which was done to exclude a carcinoma, including sarcomatoid carcinomas, TTF1 and P40 for primary lung adenocarcinomas and squamous cell carcinomas, Melan A for melanoma, CD34 and STAT6 for considering rare possibility of a solitary fibrous tumor, SMA desmin for other sarcomas, ALK for ALCL, anaplastic large cell lymphoma, CD23 and MPO. So correlating with the histopathology of the toe lesion, which was operated earlier, the immunomorphological features favored a metastatic malignant melanoma, we said, because of the S100 positivity and focal HMB45 positivity. Now, we also said the possibility of histiocytic sarcoma and an undifferentiated pleomorphic sarcoma less likely, and we asked for the blocks of the toe lesion to be submitted for correlation. Now, what happened meanwhile was because the PET CT scan was done and it revealed a solitary lung lesion and there was no disease elsewhere, the clinicians opted for lower lobectomy of the left lung. We received a lobulated, fairly circumscribed left lobe tumor measuring 8 cross 7 cross 7.5 centimeter, and it showed areas of necrosis. The pleura was free. Now, the microscopy, the features were similar to what we saw in the small biopsy. Population of spindle cells, bizarre multinucleate cells, as we saw here, lot of areas of necrosis. And we did ISC again on the resection specimen because we were unable to decide between melanoma and pleomorphic sarcomas. So the panel included S100 again, which came diffusely positive, and HMB45 showed staining of very occasional cells. Overall, it was negative. CD34 was stained only the blood vessels. H-caldesmon showed positivity. However, desmin was negative. And this BRAF stain was done hoping that it would help in diagnosis of melanoma. But I would like to ask you, is BRAF a specific stain for melanoma?
No.
Yes, because see, undifferentiated sarcomas and many of the other sarcomas are known to stain for BRAF as well. So now correlating clinical findings in prior biopsy reports, the possibility of a metastatic undifferentiated pleomorphic sarcoma is favored. Adjuvant chemotherapy was given to the patient, however, the patient was lost to follow up. So undifferentiated soft tissue sarcoma is defined as a sarcoma with spindle pleomorphic epithelioid or round cells and absence of any morphological or IHC feature of specific differentiation and absence of distinctive molecular aberrations. Now, in your PPT, you mentioned diagnosis of malignant fibrous histiocytoma. I would like to ask you, is this term still used in practice?
No, ma'am, it's not
So
used.
the term we would use is undifferentiated soft
Undifferentiated
tissue
soft
sarcoma.
tissues. Okay.
Yes. So the earlier term was malignant fibrous histiocytoma. It included four subtypes: myxoid, inflammatory, storiform pleomorphic, and giant cell. The myxoid subtype was put under high-grade myxofibrosarcomas, and inflammatory, storiform, and giant cell were classified as undifferentiated soft tissue sarcomas. At present, this is a heterogeneous group and largely a diagnosis of exclusion. That means we are expected to do a long list of IHC markers and exclude all likely diagnosis and come to this particular diagnosis. Now, this can occur in different locations and it accounts for about 20% of all soft tissue sarcomas. Etiopathogenesis is unknown. However, approximately 25% of radiation associated soft tissue sarcomas are undifferentiated and they usually show complex karyotypes. So, undifferentiated soft tissue sarcomas can be divided into the pleomorphic subtype, the spindle cell subtype, and the round cell subtype. And epithelial morphology, as we saw in our case, is less common. And when this occurs, it is most likely to be mistaken for metastatic carcinoma or melanoma. A wide range of differential diagnosis will be there, which requires clinical radiological correlation and histological assessment of multiple sections along with IHC. So the closest DD would be a malignant melanoma, as in our case, which can be excluded through clinical history and anatomical location. And melanocytic markers are expected to come positive. However, there is an entity called undifferentiated melanomas, which may show loss of these melanocytic markers. So what will we do in such cases? We will go for NGS, where a mutational signature specific to melanoma will help in diagnosis. So these are usually related to sun exposure, like BRAF, NRAS mutations, and NF1 mutations, which will indicate that it is of cutaneous origin. A dominant aging signature called cosmic 1 is most in primary undifferentiated pleomorphic sarcomas, which is not seen in melanomas. The second closest DD would be a histiocytic sarcoma, which is very rare. So we see similar cells with bizarre multinucleate giant cells, and hemophagocytosis is occasionally observed where inflammatory cells are seen within the cytoplasm of the large histiocytes. And IHC wise, they'll be positive for histiocytic markers like CD68, 163, lysozyme, and CD4. S100 immunoreactivity is also variable and ALK is negative. So other markers like melanocytic markers are expected to come negative. Now there are histiocytic sarcomas which may show alterations in BRAF. So this is CD68 and 168, 163, which come positive in histiocytic sarcomas. The third closest DD in lung location would be pleomorphic carcinoma of the lung. Now, this diagnosis can be only made on a resection specimen. Otherwise, it will be called a non-small cell carcinoma (NOS). Now, this is defined as a non-small cell carcinoma, which includes adenosquamous or large cell carcinomas with more than or equal to 10% of spindle or giant cells, and they usually come positive for pancytokeratin. That is how this diagnosis is made. However, the very bizarre spindle cells or giant cells may be negative. However, we expect the proper lineage markers like TTF1, napsin, and P40 to be expressed. Now, these are different pictures showing a pleomorphic carcinoma with spindle cells, giant cells. There will usually be a component of a differentiated carcinoma like adenocarcinoma as well. Now, this is pancytokeratin, which is showing patchy positivity. So, other sarcomas will also be in the list of differential diagnosis, especially like dedifferentiated liposarcomas, pleomorphic LMS, pleomorphic RMS, high-grade myxofibrosarcomas, MPNSD, and ALCL, which can be excluded by a long list of IHC markers. So, prognosis is generally poor, especially when there is epithelioid morphology. So thank you, Dr. Purnika, for the presentation, and I hope the next time you see a similar case when you go reach a crossroad, your IHC panel will help in
Okay,
diagnosing.
ma'am. Thank you, ma'am.
Thank you.
Next presenter can share your screen.
Yes, ma'am. Am I visible, ma'am?
Yes.
Okay. Good afternoon, everyone. Myself, Dr. Fauziya Sabrin, second year postgraduate from Dr. B.R. Medical College, Ambedkar Medical College and Hospital, Bangalore. We received case 7 with a history of 80-year-old male presented with a retrosternal mass. This slide shows a whole mount presentation showing a cellular tumor with ill-defined margins. And here we can see the tumor is inked, the inked margin, as we can see here. And on the scanner view, it shows a biphasic tumor comprising of mononuclear cells arranged in sheets admixed with numerous interspersed multinucleated giant cells. On low power view, we noted a moderate to severe pleomorphism, and these giant cells appear to be osteoclastic like giant cells. And on low power, we also noted in the periphery of the section thyroid follicles, which are separated from the tumor deposit by a fibrous capsule. And on 10x, we can see these thyroid follicles are still separated by the tumor deposit. Here we can see the follicles are lined by low cuboidal epithelium containing eosinophilic material resembling colloid. And the capsule here, we can see the invasion of the capsule by the tumor deposit and entering into the thyroid follicles on 10x. And on higher power, we can see normal thyroid follicular cells entrapped between the tumor cells, by which we can say that the tumor is invading the thyroid follicles. And on higher magnification, these mononuclear cells exhibit moderate to severe pleomorphism and showing varied morphology. Few are round to oval in shape, few are epithelioid, and also noted are spindle to fusiform shaped. In this figure, we can also see few bizarre forms. Giant cells are noted to be osteoclastic and showing many nuclei ranging up to 15 to 20 nuclei. One of the foci shows stroma containing numerous blood vessels. Here we can see numerous blood vessels in this section. And also noted are atypical mitotic figures, 3 to 4 per high power field. We can also see focal areas of hemorrhage with lymphovascular invasion and tumor invading part. This slide here shows the areas of hemorrhage with, here we can see a blood vessel showing a tumor thrombus and recanalization. Here we can also see areas of extensive necrosis. Here we can see the tumor is invading the fat cells. To summarize, this section study shows a vaguely circumscribed infiltrating neoplasm with a biphasic tumor composed of pleomorphic cells arranged in dense sheets, along with numerous multinucleated osteoclastic like giant cells. Individual cells exhibit moderate to severe pleomorphism, having varied morphology and bizarre forms, with vesicular chromatin, prominent nucleoli, and moderate cytoplasm. Atypical mitotic figures of 3 to 4 per high power field, with focal areas of hemorrhage. In the periphery of the section noted thyroid follicles containing colloid, the tumor is seen invading the capsule, fat, and blood vessels. So, with this, I give my differential diagnosis first as anaplastic thyroid carcinoma of the giant cell type, which is characterized by high cellular pleomorphism with bizarre forms and multinucleated cells. And second, my DD is poorly differentiated carcinoma of thyroid. Third, pleomorphic sarcoma. Fourth is malignant giant cell tumor of the soft tissue. All this differential diagnosis can be confirmed with the help of IHC markers. For anaplastic thyroid carcinoma of the giant cell type, I would like to go with PAX8 and cytokeratin, which are positive for this, and negative for TTF1 and cytokeratins. Poorly differentiated carcinoma of thyroid is positive for TTF1 and thyroglobulin. Pleomorphic sarcoma, which is hypercellular smear with polygonal and epithelioid like cells, but showing marked pleomorphism but is positive for vimentin, and malignant giant cell tumor of soft tissue. It is a tumor of low malignant potential with vimentin positive and a negative for S100. Thank you.
Thank you, Fauzia.
Just.
I'm Dr. Chaitra. I'll be discussing case 8 and case 7 and case 8. And I thank Fauzia for detailed description of the case. So actually, this case, when I slightly tweeted the history, it was a large thyroid tumor which was going into the retrosternal area. Why I wanted to, why I tweeted this history was many times we might not get the when the this be in the thyroid. It might be retrosternal thyroid, which is showing these features. So I won't be describing the high grade areas which you have already described, but I wanted to highlight little bit on this. The adjacent thyroid follicles, you explained the adjacent thyroid follicles, but I wanted you to go a little bit detailed on the cell, how it was. Uh, Here, the cells were arranged little bit in follicle, papillary and follicular pattern, and also showed PTC-like nuclear features. Okay, they were intranuclear. So you can see nuclear overlapping. They're all elongated. Okay, mild variation in nuclear size. There were intranuclear inclusions. See this one, and even in other areas. So you can go back and look at this slide again, because many a times finding this will make your life easy, and that's more than enough to make the diagnosis of this case. Okay, so because extensive sampling, that's what will come to your help, not the IHC. So it's extensive grossing, and finding of this very well differentiated area is the one which will give a clue to your diagnosis. Okay, all this you have described. And one more thing, what I wanted to tell you was it's very anaplastic, because one of the DD was polydifferentiated thyroid carcinoma. I'll show how the cells look in that. Okay, so here the cells here were very, that's why you had varied differentials like sarcoma also in your differentials. Yeah, so one more important thing in any endocrine neoplasm is assessment of vascular invasion. I thought I'll take this opportunity to highlight or stress on this point. So when should you, the endocrine tumors are rich in vessels, okay? So the tumor are very juxtaposed with the blood vessels. So many, we tend to get confused for like a lymphovascular invasion in many instances. So what, there's a very strict criteria or rigid criteria for a vascular invasion. So what is it? The tumor cells must be invading to the through the vessel wall, and there has to be associated thrombus adherent to it. So even even in the CAP protocol, and also many articles in WHO all highlights you should follow the strict rigid criteria for in assessing vascular invasion. So all these images which have been highlighted here are not true vascular invasion. So this was a this is from this article. This was from this initial, these two pictures are from the autopsy case where the thyroid gland was extensively manipulated, and the tissue, that follicular adenoma thing was displaced into the vessel. Even in a patient, if it either during the surgery or while crossing, it could displace the tumor cells into the vessel wall, which can mimic as vascular invasion. And this is in another case where follicular adenoma is projecting into the vessel wall. Again, this shouldn't be considered as a vascular invasion. And against loosely lying tumor with endothelial, even if it is endothelial lining is seen all around, again, that's not the vascular invasion. So there has to be vessel wall invasion with associated thrombus. So this rigid criteria has to be followed. This picture I've taken from CAP template. You can go through it, and very nice detailed explanation is given there. So all these things are not the vascular invasion. No, no, no. Only this is the vascular invasion. But if there is a tumor which is in the vessel wall and is lined or attached, looks like attached to the vessel wall, but without thrombus, but there is endothelial lining around it, it is told to take more and more deeper sections for these two. Okay, it could be representation of the means in the deeper section you might get this tumor protruding into the vessel wall, but there is still a debate on this, and you have to like see the situation and take a decision on that in such instances. Okay, the DDs given by you were all this: anaplastic thyroid carcinoma, polydifferentiated carcinoma, pleomorphic sarcoma, and giant cell tumor. And also the responses received out of 21, 15 people have called it as anaplastic thyroid carcinoma, and very few people had other DDs like paraganglioma, combined medullary and PTC, and softish solitary fibrous tumor. So let's see. Now Turin's proposal, the criteria to call polydifferentiated carcinoma is that the arrangement of the cells, okay, that is solid, trabecular, or insular pattern, and then any one of this, that is mitosis more than or equal to 3, tumor necrosis or convoluted nuclei, and there should be clear absence of PTC nuclear features. Okay, whereas in anaplastic, none of these will be seen. Like, it will be very high grade, not, I mean, this solid pattern or insular pattern will not be there. So this is how polydifferentiated thyroid carcinoma means. You can still say it is carcinoma, and these are the patterns, that is organoid, nests, okay, and solid sheets with necrosis. You can still make out they are like round, cuboidal or polygonal. They have that appearance of carcinoma and very hyperchromatic nuclei. This is classic insular pattern where it's arranged in nest with retraction artifact there. Okay, so that's why this case is not a polydifferentiated. Looking at the morphology, it's not a means it doesn't fit in for polydifferentiated thyroid carcinomas. And you told markers is essential to make the diagnosis. For generally for the cells of for the tumor which arises from the follicular cells, TTF1, PAX8, and thyroglobulin. The thyroid tumors are CK7 positive tumors. Medullary carcinomas are calcitonin positive, CEA, and as they are neuroendocrine tumors, they are positive for neuroendocrine markers. Here, the thyroglobulin will be negative, PAX8 will be negative, TTF1 can be positive. Okay, this was the present case. Actually, there were other areas where there were nice intermingling of conventional PTC and this anaplastic areas. So here, the conventional area showed pan-CK positive and thyroglobulin positive. But whereas these anaplastic areas were not positive for pan-CK, PAX8, thyroglobulin, or TTF1. That's what I told you. Actually, the IHC markers will definitely not help in many cases. Okay, the means extensive grossing and finding of this class means well differentiated area is the one which will come to your aid. Okay, coming to giant cell tumor of soft tissue, it's mostly superficial. Even though they were osteoclastic cells in this case, but the spindle cells were very pleomorphic. And again, when there is a well differentiated PTC or follicular carcinoma or adenoma, you can't make a diagnosis of soft tissue tumor, giant cell tumor of the soft tissue. Okay, this was a diagnosis: anaplastic thyroid carcinoma in association with papillary thyroid carcinoma classic type, or arising in a background of papillary carcinoma classic type. Okay, so little few lines on this anaplastic thyroid carcinoma. It is highly aggressive thyroid malignancy, which is composed of undifferentiated cells, whereas in polydifferentiated, you know it as carcinoma, but in anaplastic you have differentials from carcinoma versus sarcoma, everything. Okay, and finding of this focal thyroid follicular differentiation, or if there was a previous history of surgery or long-standing thyroid gland enlargement of the thyroid gland, might give you clue. So usually it arises de novo or associated in combination with well-differentiated carcinoma, and this is considered as endpoint of follicular cell-derived carcinoma progression. So it can have varied morphology: epithelioid, spindle, giant cell, pleomorphic, paucicellular, rhabdoid, angiomatoid, and squamous. And there could be metaplastic, chondroid, and osteoid areas. So again, means you need to, means if you're not finding this well differentiated areas, you have to rule out many other things by markers. At least try to prove they're not expressing any neuroendocrine markers or not expressing any other sarcoma markers. So these are the, means based on the morphology, these are the differentials for the differentials for anaplastic carcinoma. So a cytokeratin expression can be seen in 75% of cases, but you need to do multiple epithelial markers like CK if it's only that anaplastic areas, and TTF1 will be expressed very focally, so you might have to do in multiple sections, and thyroglobulin is almost always negative, and PAX8 can be positive in half of the cases of anaplastic thyroid carcinoma. So what's a pathogenesis or molecular abnormality you see in anaplastic thyroid carcinoma? So the early drivers, I told you it can progress from well differentiated to polydifferentiated. So either RAS or BRAF. So RAS, like if it is progressing from follicular neoplasms, or BRAF from papillary thyroid carcinoma. The late events, what we see in anaplastic thyroid carcinoma are P53 third promoter mutations, and then P10, PIK3, PIK3CA, P10, CDK, 2A. So that's what you might, when you have a only you see anaplastic areas without any well differentiated areas, you might have to use combination of cytokeractins, PAX8, TTF1, and thyroglobulin, and BRAF V600 mutation or IHC markers to make a diagnosis. So this patient is on follow-up and he has received RT and chemotherapy. He has completed his RT and continuing chemotherapy and is okay as of now. So this article means I just wanted to highlight this, how to approach a follicular thyroid carcinoma. So always any malignancy in thyroid, look for nuclear features. I hope you know the three things. That is, can you tell, Fauzia, what are the nuclear features of PTC?
Ma'am, nuclear grooving we see and overlapping.
Can you categorize them broadly into three? That is chromatin, nuclear size shape, or nuclear membrane abnormality. So under that, you have all these things. Like grooves come under nuclear membrane abnormality, clearing. Okay, so finding of 2 out of 3, if you categorize what are the, where does this fall into this three headings, then make like whether the nuclear score is 2 out of 3, that's when you call, you can put it as presence of PTC nuclear features. Okay, so important thing is any tumor, first try to find is there any PTC nuclear features, and then is it circumscribed or infiltrative. And once you make, based on that, you come to diagnosis of either PTC or follicular neoplasm. One more important thing to do in thyroid carcinoma is to say whether it is differentiated high grade. Okay, that is, look for the mitosis and look for the necrosis. So that is very important. In new WHO we have well differentiated thyroid carcinomas and high grade well differentiated thyroid carcinomas. So where you have to look for mitotic count, counting of mitosis is very important, and also sampling, adequate sampling is very important to look for necrosis. Okay. So
Yes.
say here, yeah, that's what, like this is the end stage, or it's a progression. Anaplastic thyroid carcinoma is it's the end stage in the differentiation. Okay, thank you. Thank you, Fauzia.
Thank you, ma'am.
Any doubts? Can we move on to the case 8, Dr. Gayatri?
Yes, ma'am. Ma'am, is it visible?
Yes, yes.
Good afternoon, everyone. I'll be discussing about case 8. 37 years old male was evaluated for cough with blood tinged sputum and found to have large mass involving right lung upper lobe. CT guided lung biopsy was given. This is the whole slide image showing multiple linear lung biopsy tissue bits showing biphasic tumors with both epithelial and mesenchymal elements. The epithelial component is the non-small cell carcinoma type with focal areas of squamous differentiation, which are large polygonal cells with eosinophilic cytoplasm and prominent nucleoli. On higher magnification, we can see the squamous differentiation. There is seen sarcomatous areas comprising of
spindle cells which are arranged haphazardly having elongated hyperchromatic nuclei and eosinophilic cytoplasm. There are seen few bizarre looking nuclei. On higher magnification, we can see the bizarre looking nuclei. Some of the areas show heterologous component, one being the neoplastic extracellular osteoid matrix, which is filigree or lace-like disorganized seen. Could be osteosarcoma. Focal area shows cells with eccentric nuclei, abundant granular eosinophilic cytoplasm, suggestive of rhabdoid morphology. There is seen brisk mitotic activity with few atypical mitotic figures, that is 4 to 5 mitotic figure per high power field noted. Also seen areas of tumor necrosis. To summarize, this tumor is a mixture of non-small cell carcinoma with heterologous sarcomatized component. Based on these morphological features, the provisional diagnosis is carcinosarcoma of the lung. Carcinosarcoma of the lung is a subtype of sarcomatoid carcinoma. It's a biphasic malignant tumor containing epithelial component and mesenchymal component with heterologous element. Terminology used are carcinosarcoma, sarcomatoid carcinoma, biphasic sarcomatoid carcinoma. Carcinomatous components, common epithelial types are squamous cell carcinoma, which is the most common, adenocarcinoma, large cell carcinoma. Sarcomatous components, common heterologous elements are rhabdomyosarcoma like chondrosarcoma, osteosarcoma, rarely liposarcoma or angiosarcoma. IHC used for carcinomatous component are CK positive and P40 for squamous cell carcinoma, TTF1, napsin and CK7 positivity for adenocarcinoma, and for sarcomatous component, desmin and myogenin for rhabdomyosarcoma, S100 for chondrosarcoma, SADB2 or osteocalcin may highlight osteoid matrix, cytokeratin negative in majority of these spindle or rhabdoid cells. These are my reference. Thank you.
Thank you, Dr. Gayatri.
Thank you, ma'am.
You didn't have any differentials?
Ma'am,
What was the age of the patient?
37 years old, ma'am.
Yeah. Which age is it common, carcinosarcoma?
Ma'am, it is like around average age is 60 years, ma'am.
Yeah, it can happen, but more commonly. So what else, like in a younger individuals, a huge chest wall mass, almost this mass was extending from the ribs up to the cardiac wall. Even it was infiltrating the right atrium. The medical oncologist had a doubt whether is it sarcoma arising from the heart and then infiltrating outwards. Uh, so, like, would you like to give any more differentials?
Ma'am, pleomorphic carcinoma, ma'am.
Okay, yes, then?
And any sarcomatoid mesothelioma or biphasic with
Yes,
carcinoma subtype.
exactly. Yeah.
Right now, I'm
Okay, middle-aged and then biphasic tumor. Any sarcoma with biphasic component? Okay. Actually, first, before this was biopsy done in a hospital, this patient was evaluated outside for whatever symptoms I had given, that hemoptysis and breathlessness. And the biopsy was also done outside, and we received that biopsy for review here, and that showed predominantly spindle cell component. Okay. So there were no epithelial component which was seen in the biopsy, which we have shared with you. So there we had worked up like a sarcoma. Okay. So all
Okay.
the sarcoma panels were put and everything was negative except for desmol. Okay. And then meanwhile we were working up for this, we also received this biopsy and we were lucky to have this component. The epithelial component had come up in this biopsy. So it really helped us. So I will not go to the morphology. You have described very detailedly. And as you told, this osteoid-like matrix, even I was taken away by this. So even I thought, could it be osteosarcoma? So it's mainly a biphasic tumor. Okay. So what are all the DDs now? So is it a primary from the lung or is it from mets from somewhere else? In this patient, the lung mass was a main lesion, and there was one more. There were a few lymph node mets, and there were iliac bone mets. Otherwise, there was no other primary in this patient. And so, so if it is primary, is it arising from the parenchyma, or is it mesenchyme, or is it from the mesothelium? So you have to see all the relations. What are all the anatomical structures which are there in the lung, and what are the tumors which can arise from there? So from
Okay.
primary lung tumors with biphasic tumor, I told carcinosarcoma. Other one is pleomorphic sarcoma, pulmonary blastoma, and then other things. Okay.
Metaplastic carcinoma or malignant mesothelioma.
Yeah. Okay. So the markers. Pan-CK was positive in that epithelial component, but no, not in the spindle cell areas. Okay, and
Yes.
P40, and also one more thing, you called it as squamous cell carcinoma on morphology. Just by the cell size or the arrangement, it is solidness,
Yes.
but without presence of keratinization, evidence of keratinization, you won't be able to call it as squamous cell carcinoma. Either individual cell keratinization, keratin pearls, or intercellular bridges. Those are very important than the cell size and arrangement of the cells. We call it as squamous cell carcinoma on morphology. Okay,
Okay.
but this case showed P40 staining, some weak patchy P40 staining, and CK fiber 6 was positive only in the epithelial component, not in the stromal component. And Desmin, very focal weak, but H-keldosmon was there. So, what would you like to narrow down your diagnosis from the differentials, or would you like to stick on to your? Okay, I will tell you what were all the negative markers. Beta catenin was membranous, not nuclear staining. Nuclear staining is more important. Loss of membrane is important. Okay, and all these markers were negative, like TTF1, synaptophysin, WT1D240, myod1, all these markers were negative. So can you narrow down the differentials from whatever differentials I had mentioned? Okay, the sarcoma, other one important was synovial sarcoma. TLE1 is negative, 34 is negative, and then vascular tumor, uh, um, like epithelioid hemangioendothelioma or angiosarcoma, that's ruled out. And then that osteoid thing was osteoid, which we got confused for osteoid. Probably that was just an hyalinized stroma there, or sclerosed septum. B2 was negative. Okay, so for carcinosarcoma, you told the heterologous elements described are
Ma'am, astrologous elements are osteoid-like or cartilage-like skeletal muscles, ma'am.
but for us, myogenin, myod1 was negative. Okay, desmin very focal, but myogenin, myod1 was negative, and SADB2 was negative. Okay, so. And then for pulmonary blastoma, the adeno component here will be fetal type with subnuclear vacuolation and all, and we'll have that blastomal stroma, which was
Yes,
not
ma'am.
seen. And also beta catenin, I told you it will be nuclear staining or cytoplasmic. In our case, it was membranous staining. Okay, so that rules out, and mesothelioma markers were all negative. And for synovial sarcoma, even though pan-CK was positive in epithelial component, but TLE1, CD34, all those things were negative. Okay. So, pleomorphic sarcoma, now we are left with is it pleomorphic carcinoma or carcinosarcoma. Okay. Pleomorphic carcinoma is a polydifferentiated non-small cell lung carcinoma. In this, 10% of the component can be spindle cells or giant cells. Again, here, these might not express any of the markers like pan-CK, TTF1, or P40, those markers like non small cell markers will not be expressed, and even the neuroendocrine markers also will not be expressed. So mainly finding of the CC those areas like epithelial areas, if they are either P40 or TTF1 positive, you should go with that. Even though if the markers are negative in the spindle cell or giant cell component. Okay. So main thing, there won't be malignant heterologous elements such as osteosarcoma, chondrosarcoma, rhabdomyosarcoma, which are needed for diagnosis of carcinosarcoma. If there is neuroendocrine tumor marker expression, better to call it as large cell carcinoma than pleomorphic carcinoma. And always one important thing is to make a definitive diagnosis of pleomorphic carcinoma, it should be done on a surgical specimens, not on a needle biopsies. Okay, so the pathogenesis here is it's mainly because of epithelial mesenchymal transition. So where these epithelial elements are programmed to become like a mesenchymal component, but when they metastasize, the reverse happens. So mainly it is the epithelial component which will be seen in the metastatic region. So coming to carcinosarcoma, again same thing here. It will be a non-small cell carcinoma component mixed with sarcomatous heterologous elements. There in pleomorphic carcinoma, the percentage was at least 10%. But whereas for these, there is no cutoff on the percentages. And WHO and even many articles we referred, what are the heterologous elements defined here are mainly rhabdomyosarcoma, chondrosarcoma, osteosarcoma, and rarely liposarcoma or angiosarcoma. In our case, we saw H-Desmon positive. So which tumor will be H-Desmon positive? Dr. Gayatri? Okay, so it's usually marker of smooth muscle, that is leiomyosarcoma. So you might think, okay, whether leiomyosarcoma is an heterologous element here, but just the presence of H-Desmon is not enough to call it as a leiomyosarcoma. And also H-Desmon can be expressed in many other tumors. So we have to interpret it with caution. Okay. So now where should we put this one? Like what should we call this? So it's we have ruled out all the other sarcomas. Okay. And then is it carcinosarcoma, pleomorphic carcinoma? So all this is done mainly on the resection specimens, not on the needle biopsies. So finally, we called it as sarcomatoid carcinoma. So the diagnosis of pleomorphic carcinoma / carcinosarcoma is best made on the excision bar resected specimens. Okay, so I want you to go through the guidelines for good practice of small biopsies or cytology preparation, which is given in WHO. I think the criteria means the terminology what we use on the small biopsy we should be careful in using the terminologies, and this guideline will help us while reporting the small biopsies. Okay, so these are the two tables. I recommend you, please, all of you should go through this before giving any diagnosis on a small biopsy. Okay, thank you.
Thank you, ma'am.
Then we have the presenter of case 9. Start, please.
Yes, ma'am. Is my screen visible, ma'am?
Not yet.
Ma'am, is my screen visible now?
I am not able to see your screen. If anyone else is able to see, can you put a comment in the box, please?
Ma'am, is my screen visible now?
Yeah, it is visible, but I think you should go to the PPT. You should go to the PPT. Go to your PPT and
Yes,
then share. We are seeing this KCIAPM screen only.
Once you give start screen, you have to select
now,
that.
Yeah, stop sharing the screen. Can you stop sharing the screen?
Yes, ma'am.
Yeah, and now go to your PPT.
Yes, ma'am.
Now you share the screen.
Ma'am, now is my screen visible, ma'am?
No. First you click share screen. If you click share screen, okay, in that three options will come. In that, the last one, entire screen, that you have to click.
Yes, ma'am.
After clicking that, you select your screen.
Okay, now, yeah. In your system, you should select the screen which has your PPT. The window which has PPT.
Can the...
Ma'am, is my screen now visible now?
No, ma. So, you have clicked that entire screen, right?
Yes, ma'am. I've clicked the entire screen and then
In that,
I've...
how many options are coming?
Ma'am, in
One.
that I have only two options, expand review and stop screen.
No, go to your...
One of it should have your PowerPoint.
Where is your window? Another window with PowerPoint.
Can we have the 10th person start, if you don't mind, so that we'll come back to you?
Yes, ma'am.
Just for want of time. Yeah. Case number 10, can you please start? You have to stop sharing. Dr. Dhanlakshmi has to stop sharing.
Yes, ma'am.
Ma'am, case 10?
Yes.
Yes, ma'am. Ma'am, is the screen visible?
Yes.
Yes. Good afternoon, everyone. I'm Dr. Kushala from JSS Medical College, Mysuru. I'll be presenting case 10. So the case history given was 35-year-old female with recurrent cough, no history of fever, loss of appetite or weight loss. An endobronchial mass was identified on imaging, right upper lobectomy resection specimen for histopathological examination. So we received one slide. So on scanner view, we can identify a well-circumscribed tumor located in the bronchial wall. Here is the cartilage. This is the lung parenchyma and this is the bronchus. So the bronchial wall includes the epithelial lining, the smooth muscles, and the connective tissue. The tumor cells are seen arranged in sheets, nests, cords, and trabeculae. We can also see thin-walled hyalinized blood vessels within the hyalinized stroma. Here we can see the hyalinized blood vessels. On higher power, individual cells are epithelioid to ovoid with vesicular nuclei, inconspicuous nucleoli, and moderate amount of eosinophilic cytoplasm, interspersed with fine strands of collagen and thin wall blood vessels. This is the same, showing the cellular morphology of epithelioid to ovoid cells with vesicular nuclei, inconspicuous nucleoli, and moderate eosinophilic cytoplasm. These are the thin wall blood vessels. And you can see hyalinized stroma. Many thin wall blood vessels and hyalinized blood vessels are also seen. At one foci, the tumor is seen extending to the stroma adjacent to the cartilage. To summarize, sections show a well-circumscribed tumor in the bronchial wall composed of cells arranged in sheets, nests, cords, and trabecular patterns, interspersed by many thin-walled and hyalinized blood vessels. Hyalinized stroma noted. Individual cells are epithelioid to ovoid with vesicular nuclei, inconspicuous nucleoli, and moderate amount of eosinophilic cytoplasm. No evidence of mitosis or nuclear atypia or necrosis seen. Based on the morphological features and clinical history, my first differential diagnosis is salivary gland neoplasm, suggestive of myoepithelioma, and my second DD is perivascular epithelioid cell tumor, PEComa. Points favoring myoepithelioma. The first one is the patient complained mainly of recurrent cough with no history of fever, loss of appetite, or weight loss. And the location on imaging showed an endobronchial mass
which was well circumscribed, multilobulated, which was arranged in solid sheets and nests in a hyalinized stroma with absence of necrosis, hemorrhage, or invasion. Points favoring PCOMA, it was a well circumscribed lesion with epithelioid cells arranged in sheets or nests with perivascular arrangement with delicate vascular to hyalinized stroma. Points against PCOMA, PCOMAs have solitary nodules which are located mostly at the periphery, and these are the IHC markers. So the probable diagnosis would be salivary gland neoplasm suggestive of myoepithelioma. Thank you.
Thank you. Can you stop sharing the screen?
Yes, ma'am.
Can you see my screen?
Yes, ma'am.
Okay. So excellent presentation. Your DDs were same as what we had also thought when we had received the case. And these were the different responses from from those who submitted. And we can see here many people have thought of solitary fibrous tumor, which we also thought. And glomus tumor was another DD which was given, apart from other tumors like myoepithelioma, schwannoma, and carcinomas and sarcomas. I just show the pictures which you have not covered. So this was the gross resection specimen, and the arrow here points to the tumor, which is predominantly growing inside the bronchus. And the one focus which you showed also is something which I wanted everyone to see, and so I had given this slide. So the microscopic features are same as what you had suggested. So I'm not, just for want of time, I'm skipping those. So overall, a spindle to epithelioid looking tumor, possibly a low grade appearing tumor. So with all these differentials, we went into these IHCs. So now your DDs were PCOMA and myoepithelioma. So myoepithelioma gets ruled out in this case because pancytokeratin was negative. The DD of SFT gets ruled out because STAT6 and CD34 were negative. And the other DDs, schwannoma gets ruled out as 100 negative. PCOMA, again, HMB45 was negative. Neuroendocrine tumors, which some had thought, it was again negative for the markers. The other markers here we had added for the DDs of synovial sarcoma, inflammatory myofibroblastic tumor, and very less likely whether if it was any female genital tract origin tumor, and so the CD10 progesterone receptor, all these were done. The only positive markers we got were strong positivity for Vimentin, SMA, and focally for Caldesmon. So, would you want to say anything about this? I just wanted to point out some areas here which were looking with more myoid-like. So these areas were Caldesmon positive, but overall the SMA was diffuse and strongly positive. So by excluding all these DDs and considering a low-grade round to spindle tumor with a lot of blood vessels, we came to the conclusion of a glomus tumor, but a glomangiomyoma with uncertain malignant potential. I will explain why we considered that. But just one point for those who are listening, the youngsters. So glomus tumors are basically tumors which are originating from the glomus body, which is a neuromyoarterial structure, and so it is commonly seen in the distal extremities. So if you think of glomus tumor, the first thing, please think of a distal extremity and not the lungs. So because this was a rare location, we wanted to present this. And glomus tumors are classified as benign or uncertain malignant potential or malignant tumors based on their morphology as well as some atypical features. In this case, it is a deeply located tumor. The size was 3.5 centimeter. Apart from this, some slides which we hadn't shared just for want of the space, some had shown some nuclear atypia. So with these, we had called it as a glomus tumor of uncertain malignant potential. If anyone has any queries, please post it in the comments box. Just out of time, I'm just going off to the last case. Case number 9, can we start?
Yes, ma'am.
Dr. Dhanlakshmi is able to share her screen.
Yes, ma'am.
Yes.
Ma'am, is my screen visible?
Yes, yes.
Good evening, ma'am. I'm Dr. Dhanlakshmi, first year resident from Command Hospital, Air Force, Bangalore. And I'm here to present the case number 9 with a history of 59 years old male with recurrent cough on and off 2 years and no fever. Endobronchial mass at the right lower lobe bronchus detected on imaging. And right lower lobe resection was done and the specimen was sent for HP. So coming to the HP section of the resection specimen, ma'am, in a low power, we were able to see that the total tumor was only limited to the bronchus, and it also been seen that the tumor is arising from the bronchial epithelium. I've further zoomed it to show you the uh, origin of the tumor from the epithelium. And then on further this thing magnification, we could see numerous epithelial fronts and stromal crops with stromal cores with micropapillary tufting. And there on further magnification, the cells were uniform columnar cells with eosinophilic cytoplasm, round to oval vesicular nuclei, the regular nuclei, few showing nuclear grooving, ma'am. And there were the underlying stroma showed hyalinized vessels, few containing inflammatory vessels, and few hemosiderin laden macrophages noted. There were no goblet cells or mucus cells noted, along with cellular crowding or nuclear atypia or mitosis or invasion noted in the section. So, depending on the history and the morphological features, these are my differential diagnosis, which I have divided them as per the localization, essential morphological features, and epithelium seen. Localization coming to bronchial papilloma, which is of glandular variant, is central and endobronchial, and the ciliated muconodular papillary tumor or the broncholar adenoma is peripheral and peribronchial, which excludes our location of the tumor. And sclerosing pneumocytoma, which is a solitary and peripheral, but it can be rarely endobronchial, so it has been included in my differential diagnosis. Then coming to papillary adenoma, it is also a solitary and peripheral. Due to the papillary structure architecture, I have included it in my differential diagnosis. The essential morphological features are papillary architecture is usually seen in bronchial papilloma, and the circumscribed papillary architecture is also visible in ciliated muconodular papillary tumor. And sclerosing pneumocytoma also shows the patterns of papillary sclerotic solid and hemorrhagic growth patterns. And papillary adenoma is an uncapsulated, circumscribed peripheral papillary glandular neoplasm. Coming to the epithelium, it is lined by non-columnar, non-ciliated columnar, cuboidal or globulate cells. A bilayer in ciliated muconodular, it is bilayered cellular proliferation of luminal epithelial cells and subjacent basal cells. Whereas in sclerosing pneumocytoma, we can find dual population of surface and round cells. And in papillary adenoma, we see single layer of cytologically bland cuboidal to columnar cells lining fibrovascular cores. And coming to the IHC, because only on morphological basis I included this thing, and depend on further IHC or markers, we can differentiate it from each other, ma'am. And the bronchial papilloma are TTF1 negative, and ciliated muconodular papillary tumor are P40 and CK57 positive in basal layer and TTF1 positive in luminal cells. Positive draft mutations are associated with it. And sclerosing pneumocytoma can be differentiated with TTF1 and EMA positive in surface and round cells, cytokeratin positive in surface cells but weak or absent in the round cells. Whereas papillary adenoma can be differentiated with the TTF1 positive. So based on the morphological features, my provisional diagnosis is bronchial papilloma, which is of a glandular variant. And further IHC is recommended to confirm the diagnosis. Thank you so much, ma'am.
Thank you. That was a good presentation. Can you stop sharing the screen?
Yes, ma'am.
Thank you. You can see my screen now.
Yes, ma'am.
Okay. So yes, so you have approached the case as a tumor which had papillary morphology, and then you have developed further based on the location as well as the psychological features.
Yes,
So,
ma'am.
for the overall responses, apart from considering carcinomas, the other DDs for this case which everyone thought were metastasis versus, say, summary I've put here, benign tumors with papillary morphology, adenocarcinomas. Some have considered neuroendocrine tumor and some have considered salivary gland tumor. So all are acceptable considering the patterns that we are seeing here. So you have already shown these, so I will just skip off to a few things which are not matching exactly. For this, now you have not described this part. The reason for giving this was that never miss out if there are two pathologies in one case. So in the adjacent lung, there were a few granulomas, as you can see here. The typical horseshoe-shaped nuclear arrangement, as well as the slipper-shaped nuclei in the epithelioid histiocytes. So here, the cytological features now are, at least by your description, they are bland. So if you have a close look, you can look for that stippled chromatin in this case. And regarding which type of carcinoid it would belong to, that would depend on the mitotic count as well as presence of necrosis. So based on the features in this case, this was a typical carcinoid, and there was also a foci, and there were also foci of granulomatous inflammation. So this was the IHC of this case. As you can see, the positivity for pan-CK and neuroendocrine markers. So you have thought of a bronchial papilloma glandular variant. Now, if you see the contrast between the two, you have abundant hyalinized stroma when you think of a papilloma, whereas in neuroendocrine tumor, it's a very cellular tumor. So you have very thin papillae, if at all, the cores are very thin. And you don't see the non-ciliated cells and interspersed mucous cells in this tumor, whereas you can see that here. So the other DDs where people, some of the doctors have thought of carcinoma. So mainly it is the nuclear morphology, which will help to differentiate from neuroendocrine tumors. However, the exception would be a large cell neuroendocrine carcinoma, which can have all the features similar to an adenocarcinoma in some of the cases, prominent nucleoli, etc. And some have even thought of a small cell lung carcinoma, maybe because of the blue color of the overall, the slide appearing blue in color. But again, you'll have to look for the nuclear molding and presence of numerous mitotic figures as seen in this. All these pictures are from WHO, so you can definitely go back to compare. And some have considered atypical carcinoid. Again, it is due to, it is because of presence of necrosis, which is usually punctate. Some areas were present in the slide which were looking very pinkish in between the tumor cells. So these were not exactly necrosis in this case. It is more because of related to prior biopsies as well as due to the obstructive features of the large tumor. So again, we have to be careful, and we can correlate both with morphology and with Ka67 only when we need to differentiate it from a higher grade tumor. And in this case, salivary gland tumors are not considered, again because of the nuclear features here. So if we go back to WHO, we have this table which differentiates. So the one point I want you to remember here is Ka67 is not used to differentiate these categories. It is only by the mitotic count and presence of necrosis apart from the cytological features. So remember, Ka67 should be used only for in crushed samples if you are confused between a high grade tumor like small cell carcinoma, large cell neuroendocrine carcinoma. Do not use a Ka67 between a typical and an atypical carcinoid. So with that, I will stop sharing this part. I will now request Dr. Rekha, our senior consultant and head of the department, to offer her concluding remarks. You can.
Hello. So thank you all. I hope you enjoyed the cases that we had selected from the thorax. The first years and the seniors did a fantastic job. And they're obviously working hard under the supervision and guidance of their teachers. And all of us wish you good luck in your journey in pathology. It's long and arduous, but very fulfilling and satisfying. With Aditya's permission, I will just take 2 minutes to share two announcements that we have. One is that we are having a CME in cytopathology on the second Saturday in September, September 13th, where we have very distinguished speakers coming. Dr. Ashish Chandra from Guy's Hospital, London, Dr. David Kim from MSKCC, Dr. Radhika from PGI, Dr. Siddharaju from JIPMA, and Dr. Priska from CMC Vellore. Posters are also welcome, and the details are in Patho India. The second announcement is that registrations for our fellowship in tumor pathology are now open. Again, the details are in Patho India. So I invite all of you interested in oncopathology to apply, and we look forward to responses from you. So finally, thank you all very much. I think all of us enjoyed ourselves, and I wish you a very good day. Thank you.
If any queries are there, you can continue posting the post. Just we had
Thank
to
you,
run
ma'am.
fast for the time sake. But if any queries, you can continue posting.
Thank you, ma'am. Thank you, Rekha, ma'am. Thank you, Dr. Shanti, for the wonderful set of cases. This is actually a good initiative that all the cases belong to a single system, wherein PGs could actually plan their study. This is actually something that we are planning to implement from next year, wherein every month slide seminar will be from one system,
Yeah.
so that PGs can actually plan their preparation for exams as well together with us. Thank you, ma'am, for giving us a brief insight into how next year's slide seminar will look. Thank you, ma'am. With that, I think we can close the session.
Yes.
We will be sharing the certificates to all the PGs and the faculty by tomorrow evening. And looking forward to meeting you all next month for the August slide seminar. Thank you all.
Thank you. Thank you. Bye bye.